Good morning. It's 8 o'clock, so I'd like to get started. If everyone can just finish gathering their food and take a seat. I'll give everybody maybe a minute to do that, and we'll get started. Okay. Good morning and welcome to the 2024 Winter NRG Symposium on Inclusion, Diversity, Equity, and Access of Underrepresented Patients in Clinical Trials. My name is Bhavana Pathuri, and I'm honored to chair this event along with my co-chair, Dr. Jeffrey Hines, who will introduce himself to you in a few minutes. We would like to thank Dr. Angeles Alvarez-Secord and Dr. Ronnie Alvarez for their vision. This idea started over a year and a half ago, and it has come to fruition today. So thank you for enabling us to put on this idea symposium and highlight this really important topic. I'm a gynecologic oncologist at NYU. I also serve as the medical director of clinical trials at the Perlmutter Cancer Center. I also serve as the director of diversity and health equity for clinical trials for the GOG Foundation. I've had the wonderful opportunity to collaborate on a joint guidance paper with SGO and the GOG Foundation. We've also represented GOG Foundation at the first annual GCIG Endometrial Consensus Conference in Korea, and IDEA will be included in the consensus paper and incorporated in all future endometrial cancer trials developed globally. We will continue the commitment to tackle the issues we'll all be talking about today with colleagues around the world at a future IDEA meeting in Barcelona next month. I am particularly passionate about diversity and health equity for clinical trials, as it is near and dear to my heart, as I believe that all patients should have access to novel therapies, and it is imperative that we study the safety and efficacy in all patients that are representative of the population expected to use the medicine. In addition to facing implicit bias, our patients may have social determinants of health, language barriers, lack of literacy, underinsured or undocumented status, financial or other burdens that impact their disease course. Perhaps they have faced a late diagnosis or higher stage disease as a result. They may be sicker than some of our other patients, and there may be unique molecular differences to their cancers. I am so excited to work with all of you on beginning to overcome these issues. By the time you leave us this afternoon, we hope you will recognize the barriers that underrepresented patients encounter with clinical trial participation, as well as identified barriers related to physicians and care teams with relation to clinical trial opportunities for diverse patients. In addition, you'll be able to explain institutional barriers to clinical trial access and to distinguish ways in which advocacy at the local, community, and national level can be leveraged to improve IDEA. Finally, you'll be able to identify and improve protocol design and implementation barriers to clinical trial accrual of underrepresented patients. We will have some cases where we will break you up into small groups for discussion to help engage you in active learning. We have the honor of having with us a marvelous panel of expert faculty and diverse patients. The patient voice is powerful and will further help us learn how best to move the needle together. Our moderators and speakers will help us all understand and give us the tools to improve IDEA in clinical trials throughout the country. After the conclusion of the meeting, we will send you a follow-up email with a link to resources to help you continue this work at your own institutions and continue to pay it forward. And together, we will increase IDEA of underrepresented patients to clinical trials. Now I will turn it over to Dr. Jeff Hines to introduce himself and kick off the meeting. Thank you all so much for attending today.
Thank you and good morning, Bhavana. Good morning, everyone. Good morning, everyone. All right. I'm Jeff Hines. I'm a gynecologic oncologist at the University of Connecticut Health Center. I also serve as the Chief Diversity Officer at the University of Connecticut Health Center. and proudly serve as the chair of the Diversity, Inclusion, and Health Equity Committee for the Society of Gynecologic Oncologists. It is truly a pleasure to be here this morning, but it is more of a pleasure to work with Bhavana, with Michelle Small, the amazing faculty and patients that helped to put this symposium together this morning. Equally, I thank each of you for your participation today. We are going to be in a disruptive space, if you will, today. We are not going to lecture at you. We are excited to bring you present into this space, to be proximate in this space, and to be participatory as we discuss the importance and continue to embed equity, inclusion, and diversity for patients that we take care of with malignancies that have been historically excluded, who have been racialized, who have been minoritized, who have been oppressed. So we're excited to have you into this space today. A couple of housekeeping issues. After the cases are presented, we're going to divide you. This room doesn't lend itself specifically to a division, but we're going to make it work. We're going to ask tables 2 or 3 at a time to get together to discuss the cases after they're presented. We're going to give you 10 minutes to do that tabletop exercise. After that, we will ask 4 to 6 groups at a time for a very brief distillation of what the comments were at the group. And between the 3 cases that we will discuss today, we'll get around the entire room. Also, for our virtual guests, there'll be an opportunity for you to ask questions through the chat, and we'll be monitoring the chat. So again, it's very exciting to be here with each of you this morning. And I want to cue up a video that John Farley from Arizona sent us, because it really provides firm grounding and a framework for what we're going to discuss today. So if we can cue up the video, I'll come back in a few minutes. Thank you.
What is your message to the medical community? What more do you want to see done?
Yeah, definitely more training, more implicit bias training. You know, there's countless stories of women not being heard when they are in the delivery room at doctor's appointments. I don't think you should have to be prepared to advocate for yourself. I think it's intimidating for a lot of women. You know, the doctor is the expert, and so to have to really push up against them is difficult. And so that's one thing. Policy change, of course, you know, at that level is very important. And then just the awareness of it all as well. And I think we just have to remember these stories, these people, and not be detached from that as well.
Thanks for watching. Stay updated about breaking news and top stories on the NBC News app, or follow us on social media.
Thank you. Those are very powerful words for those of you that know Allison Felix, who suffered significant complications, and there are other professional athletes, and particularly Black women and other folks that have suffered significant complications due to obstetrics. But it certainly frames the work that we're going to do here today. We're going to talk about some individual mitigation strategies. We're going to talk about institutional strategies. We'll also importantly talk about some systems and structures. So with that, it's my pleasure to introduce our 2 moderators for session number 1. First, Angeles Alvarez-Secord, who is president of the Society of Gynecologic Oncology. She is the director of Gynecologic Oncology Clinical Trials and the associate director of Clinical Research Gynecologically Oncology Program at the Duke Cancer Institute. It is a pleasure to introduce Michelle Lightfoot. She is an assistant professor of gynecologic oncology in the Department of Obstetrics and Gynecology at NYU Langhorne Health and Perlmutter Cancer Center. So if we can cue up the first case, I'll go ahead and get started while we're waiting. The first case is Tanisha Young. Tanisha is a 54-year-old Black female. Thank you. She was recently operated on by a gynecologic oncologist at your academic medical center for metastatic ovarian cancer. Her final staging is a T3, N0, M0, FIGO stage 3C, low-grade serous carcinoma of the ovary. She was optimally cytoreduced. She has a wonderful performance status of 1. When she was hospitalized, she screened positive by SDOH screening for food and transportation insecurity, and she lives in a medically underserved area as defined by HRSA. The tabletop exercise that we want you to do, you are presenting this case at your tumor conference. You're the PI or a member of the research team. The patient is being presented, she's being considered for a clinical trial. You overhear a member of your research team quietly tell another member, why bother to enroll her in this trial? Those people from that community never are compliant. So what we're going to do is break you up. What I'd like to do is to do it in rows. We have 2 rows here, 2 rows in the middle, 2 rows on the side. If you can just kind of congregate in groups of 2 to 3 tables, we're going to take 8 minutes for this first session to discuss what question prompts that we have for you. If we can put the question prompts. But the prompts are, what is othering and how would you address othering? And then, what does your research team look like from a perspective of race, ethnicity, gender assigned at birth, sexual orientation, gender identity? And what would you do to address the composition and representation of your research team as you treat and enroll patients on clinical trials? So we'll give you 8 minutes to discuss this, and then we'll probably ask 2 or 3 representatives from this column or these 2 rows at first to give a very brief 1 to 2 minute distillation of what you discussed at the table. So if folks can gather around, and can we put the question prompts up? I don't know if they're available, but if not, I'll go over them again. What is othering, and how would you address this in your research team? And then from a composition perspective, what does your research team look like, and what do you do to address that?
Yeah, I'll add that they're all on your tables, so you can find case 1. The questions are there. We would like at least 1 from each group filled out completely. We are going to collect those and compile the answers and then provide that all back to you at the end of the meeting.
Myers and Dr. Lightfoot. Oh, there it goes. All right, everyone. We're going to have the panel members come back up, Dr. Myers and Dr. Lightfoot. As they're making their way back up to the podium, I just want to remind you, please write down some of your responses from your small groups, because we're going to come back and share that with everybody. And if you like where you're sitting right now, you don't feel like you need to move back. You can stay in this configuration. But this has actually been really fun to have this interaction component. All right, Dr. Lightfoot, I'm going to pass it off to you.
Great. Thank you, everyone, for participating. I know at my table we're having an excellent discussion. So next, I have the pleasure of introducing Dr. Tashana Myers. She is Associate Professor at the University of Mass Chan Bay State. She's also the Vice Chair of Academic Affairs in the Division of GYN Oncology and on the Board of Directors of NRG Oncology. She's going to talk to us about let's educate and address social determinants of health. Thank you. And if we can pull up her slides.
All right, thank you everyone. It was a very rich conversation, and I'm sorry to interrupt it, but I think this will add to the conversation. So I'm gonna talk about social determinants of health, just in the definitions. So this is gonna be like a 1985 poll everywhere. I'm gonna ask you to just raise hands. So have you ever been unable to answer a trial because you didn't have it in a specific language for a patient? All right. Have you ever needed to explain that you couldn't pick the arm of the trial that the patient was going to randomize to? All right. And then have you ever had patients travel more than 2 hours? And that was just for regular care, right? This isn't the cutting edge clinic. Okay, so this is us, right? This is the conversation. I don't know if I've ever thought about it under this heading, but we will now. So the U.S. Department of Health and Human Services defines it as environmental conditions to which people are born, live, learn, work, play, worship, and age that impact health, function, and quality of life outcomes. I'm going to go through these 5 categories just so we can begin to reframe the situations that we encounter every day. Education, access, and quality. So people with a higher level of education are actually more likely to be healthier and live longer. Education affects the basic literacy, but specifically healthcare literacy. And imagine if English is not your primary language, trying to navigate not only the language, but healthcare. It becomes more complex. So how does this all trickle down? So if you're actually able to achieve an education, you're able to get a better job, get health insurance, you're able to navigate healthcare in general, your healthcare literacy goes up. You then avoid the things that are adverse to your health, drugs, alcohol. You then participate in exercise, and ultimately it leads to healthcare equity. When you think about the environment, what is the space that our patients are living in before they walk into our offices? Many patients in the United States live in neighborhoods with high rates of violence, unsafe air or water, and other health and safety risks. The built environment is more than just the home. It's the buildings, the streets, the open spaces, the infrastructure, as well as access to transportation. It includes inaccessible or non-existent sidewalks and bicycles or walking paths that contribute to sedentary habits. We know that sedentary lifestyles are associated with cardiovascular risk, diabetes, obesity, and in some cases, some cancers. So when we think about how our neighborhoods are assessed, they're really divided by race and socioeconomics. And resources are allocated differently. The quality of the schools, the quality of the grocery stores. And living in that environment, then you develop behaviors to be able to live in that environment. Maybe you smoke or drink or develop depression in order to cope. And ultimately, these chronic stressors will affect your health. Our relationships. So people's relationships and interactions with family, friends, coworkers, and community members can have a major impact on their health, right? Like, people can kill you. So if you think about it, being in these healthy, positive relationships, having connectedness to each other, the effects of bullying, being in an abusive relationship, incarceration, your partner's incarcerated, your children are incarcerated, your children are addicted to drugs, your partner's addicted to drugs. This is what you go home to after you leave the infusion suite, right? What are the impacts of these things on your health? Sorry this is so small, but essentially there was 148 studies that they looked at. And what they realized is if you had a high social support, if you had complex interactions, that's the top of the grid, that it actually improved your survival. 50% higher rate of survival if you were connected or had social support. Are we asking those questions about who's your village? Who supports you? The last two will be economic stability. So in the United States, 1 in 10 people live in poverty. And many people can't afford things like healthy foods, healthcare, and housing. Housing insecurity, broadly defined as high-cost housing, lack of stable housing. How many people are living with friends, sleeping on a couch, having to have different friends stay with them, or stay with different friends? Frequent moves, poor living conditions, and unsafe neighborhoods. Employment rates. Do you make enough to actually pay your rent? And if you do pay your rent, do you have enough to then buy food and pay your utilities? Do you live in a food desert? Could you access, by walking or by bus, a normal grocery store? And healthcare access. So about 1 in 10 people in the United States don't have health insurance. Without health insurance, you're unlikely to have a primary care or do all of those preventative screenings, which we know are impactful, or obtain medications. Can you pick up your antiemetics? Are there enough physicians in that area? And then what is the quality of care? At our institution, I like to call it a hospital with a little h. So technically it's a hospital, but really when you're sick, it's not the place that you need to be, but it's your local hospital, and so that's where people go for care. And are patients living too far away from healthcare to even tap into those systems, be it a hospital with a big H or a hospital with a little h? And all of this, we now know, is called allostallic load. It's a cumulative measure of physiologic damage secondary to cognitive, emotional responses, and perception to socio-environmental stressors. We know, at least in the breast literature, that it's associated with an all-cause mortality increase. So how do social determinants of health show up in research? Transportation. Can you get to the appointment? And it's not one, right? It's the CAT scan, it's the EKG, it's the lab draw, it's the pre-chemo evaluation, and then treatment. Can we do video consenting? Well, not if you don't have Wi-Fi and bandwidth. Do you have childcare if your infusion is at 7:30, but you have to drop your kid on the bus at 8? Is there food insecurity? And then some of the worst ones, I think, are not lack of insurance, but the underinsured. You have just enough insurance, but not really to get the care that you need. And what is the cost of participation? The co-pays, the time off from work. Is your job secure if you leave for treatment, pre-chemo, CAT scan? That's how it shows up in our research world. So here are opportunities, and my colleagues will delve into this more so. But screening tools. We have to figure out who these patients are and what the needs are. These are several of the ones that are available. You all may be doing versions of this in your own institutions. You know, the kinds of questions that they're asking is, what is your living situation today? Do you live in a place that you have problems with any of the following? Mold, lead, lack of heat, water leaks. And then within the 12 months, the food you bought didn't last. Is this always, sometimes, or infrequent? You know, these are different types of questions than we were trained to ask. And thankfully, we're now more aware that these are the questions we should be asking. We have to build access, so information in primary languages. We have to advocate. All of us actually need different languages, depending on where we are. And so knowing what are the top 3 languages that you need for your institution. Healthcare literacy. You know, I think we get so excited talking about cutting-edge science with clinical trials, but we have to talk about ovarian cancer. Like, what is ovarian cancer? What are your ovaries, right? Going through that anatomy. Research result transparency. You know, so many people said, I just want standard of care, and I have to reflect, standard of care came because a clinical trial was done, and making those connections for our patients. Helping patients to find the clinical trial information so that they can advocate for themselves. And then reaching out so that they have contact with us as the big healthcare systems to have access to trials. And then trials materials which connect with our diverse populations. These, again, are just some examples of you know, the diversity in our patients and the diversity in our workforce. Build your team. So community health workers, we should invest in educating and utilizing community health workers. These are trusted members, they are non-clinical of the community. And they're a person who understands the community. Educating these team members on gynecologic cancer and clinical trials will be invaluable. Ask for the funding to support this role on your team. Patient navigators, our patients desperately need help getting through the healthcare system. These are our internal advocates to support and guide individuals that help with the system. They coordinate the care. They make sure that the EKG, CAT scan, and lab draws are all happening on the same day, right? What does that add in terms of that person's life and time? And then they guide throughout care and the clinical process. My final thoughts are, how are you screening for social determinants of health at your institution? If you don't know, I challenge you to go back home and find out. And then what are the resources? So now that we know what the problems are we equipped to actually address them? They may be hospital-based, but more often they're community-based. Thank you for your time.
Thank you, Dr. Myers, an amazing distillation. Before we get into the second tabletop exercise, we want to give different groups an opportunity to report out on the first case. So if representatives just want to come up to the mic just for a minute or two and talk a bit about what the conversation was like at their table regarding othering and bias and what their research teams look like from a compositional perspective. So please come up to the mic and share if you'd like. Thank you.
I'm Jo Casablanca from Atrium Health, Wake Forest Cancer Center. Nice to see you. We had a lot of conversation about what othering is. Admittedly, we did Google it. But what we felt that it most was this us versus them type of thinking. And so some of the things that we talked about at our table was trying to address this way of thinking with implicit bias training, with the Just Ask program, role modeling. And then in the topic came up about the diversity of our research team, and we got into how difficult it is to increase the diversity of our research team based on who's available in the workforce in our community, the way that recruitment is done, the way that people access the job postings is a very traditional way. And trying to increase diversity would mean recruiting folks in underrepresented minority groups, specifically at their universities, or going outside of the traditional job recruitment pathways to increase diversity, because it seems that we are just using kind of our usual hiring practices, and that leads to the same people getting hired over and over again. One of the topics that did come up was that a lot of our cancer centers are doing a good job at screening for social determinants of health and looking for the gaps for patients, but the resources to address them is where it falls short. Thank you.
Thank you for sharing. Anyone else? We can pick up on some of the conversation in our discussion at the end, but anyone else want to share just a few comments on that? You know, this is work that shouldn't be done in a vacuum. Obviously, there are partners internally and externally to our institutions that can often help us with providing some of these resources. And we go through case number 2, we'll get into some more details about where there can be some partnerships. But anyone else care to talk a bit about othering, bias, compositional diversity of our research teams, challenges, what can we do to better improve that? Any other comments at all? Thank you.
I'm Dana Chase. I'm at UCLA. We had an interesting conversation about maybe some of the barriers in Korea. Not to put you guys on the spot, but it was interesting to think about socioeconomic barriers, and maybe the flip side of that is burnout on the side of the research staff in terms of having the resources to address challenges that might come up in a patient that's of a different socioeconomic status, and how this maybe secret conversation between this research staff member and the person sitting next to her reflects maybe burnout and lack of resources on the research team side. But maybe some also interesting challenges in Korea that maybe are different from the United States.
Thank you. Anyone else? Comments? All right. Please.
Can you hear me now? So I wanted to go back to the comment Dr. Casablanca made, because I went through this a few years ago where I really wanted to be intentional and hire somebody that was from a underrepresented group, because I think that it's important for patients to be able to recognize somebody they feel more familiar with, and that may enhance enrollment. It was very challenging, and so I'm going to put Dr. Barrett on the spot for a second, because I know that some institutions have ways that you can intentionally reach out to those types of, or those individuals outside of the traditional way that we do job advertisement.
Well, thank you. So there's a couple of things that we've done in the past, and I'm actually in the process of hiring people now in my new role over at Wake Forest after leaving Duke. And it's interesting because when you see the screening process, you get, and tell me if this is consistent for all of you, but your HR typically will screen for you and then send you candidates who they think fits. Is that right? to kind of show me a hand. Okay, great, I see head showing. I found that to be highly problematic, right? Because oftentimes, and again, nothing against HR, I love HR, but just wanted to note, however, that what happens is you end up with people screening for people who, one, don't really fully understand the breadth of the job, right? And two, they oftentimes are not necessarily having this lens of diversity in it. Now, when we say diversity, I always have to be careful because I think we can simply think that we're picking people based on their race and not based on their qualifications. The point is that they actually all qualify, and then you start to think about what the diversity is across your group. But what I've started to do, and it's actually worked well for me and other members and other colleagues, is asking for the full list. Not that I want to look at all of them, but I actually look at them and then I ask HR, can you tell me the race and ethnicity, because I want to make sure that I'm being very specific on who I'm trying to identify as qualified candidates for the work that I'm doing. So one is, when they get that list or when you get that information, ask them to make sure, before you even do it, ask them, look, we really want to make sure we're having a diverse pool here. What other strategies are you using as HR to ensure that we're getting a diverse candidate pool that you're pulling in? So that's one. And then second, depending on the roles that you're looking for, I've actually been working a lot with our local community colleges, especially on the research side, and developed a whole program at Duke called the Equity Scholars Program. And now those students who are coming out with their associate's degree in clinical research or public health are now becoming people who we're hiring. And then when they come into Duke, they now can work at Duke as a full-time job, and Duke pays, as you know, part of their college career. So now the next 2 years can be actually covered through the institution while they're also working and getting experience. So really and truly, 70% of people who are at HBCUs, and particularly at community college, are from underrepresented, marginalized groups, and they oftentimes know their community well because they live there. They've been living there for a while. Unlike four-year institutions, people fly in from all over the place to come to the schools that we belong to. So those are two, but I would have definitely called the HR and ask your HR populate group to say, look, let them know you are specifically being intentional. Then it alerts them to actually say, okay, I can't just kind of scan through and send. I actually have to be really thoughtful about it.
Yeah, I think that relationship with your HR colleagues is critical. Many of us live in communities, for instance, we have an ANAPC institution, Asian American, Native American, Pacific Islander serving institution, and we have Hispanic serving institutions, and we've been very intentional with our HR colleagues to reach out and develop pathway programs for a variety of different employment opportunities at our institution. We actually call out the importance of the research enterprise at our institution in looking for those candidates. Kimberly Richardson.
Good morning. I'm going to turn my back to you all because I really want to project this to the room. I'm a Black patient advocate, an ovarian cancer survivor, and I'm going to be speaking probably in the next hour or less than. And I need to say this to the room. I'm sure that in the breakouts that you all were having some really in-depth conversations, but to only see one or two people come to this mic and really want to talk about what your groups were talking about is sort of disappointing to me as a Black patient advocate. I need to hear from you. I need to hear that you as providers understand these issues, want to grapple with these case reviews. And maybe we can do this at the second one, but I'm really looking forward to hearing from you because as a Black patient advocate, I advocate for you. I try to make sure that residents and patients and caregivers understand your side of the story. So please, today, let's take this opportunity to be uncomfortable and speak up. So I have something to go back to people and say, yeah, your providers really do care. So thank you.
Thank you, Kimberly, for that, emphasizing that charge to all of us in the room to be a bit vulnerable, uncomfortable, and inconvenienced by this conversation today.
I would like to just ask, I was sitting at the table in the far back, and we had a very interesting conversation about what do you do if you don't really have the ability to hire a diverse workforce. There are some areas that you just can't do that. So I would love for one of you guys to come and speak, and make Kimberly happy. Thank you.
Hello, I'm Lindsay McElharning, gyne-onc at the University of Nebraska. And from the back table, we were talking about how challenging it can be to diversify the composition of your research team. My entire research team is all female Caucasians. Things that we talked about were initiating diversity or inviting diversity officers to team discussions. So like a tumor board meeting or a research team meeting, active learning sessions within a team. In terms of at that tumor board, really trying to kind of immediately shut down the othering and focusing on the people who had actually maybe met the patient, and then really looking at the inclusion criteria for a particular trial, and if a patient appears eligible, kind of starting there. And then if there are social determinants of health that may hinder their ability to participate easily, then really trying to address what we can do to help that patient be successful on that trial. Thank you.
Thank you.
Okay, so we are going to move to the second breakout case. So I'll just start. So this is a young woman diagnosed with locally advanced cervical cancer. At initial presentation, she was offered standard of care chemoradiation with immunotherapy versus a clinical trial with chemoradiation and a bispecific. Admittedly, this is a history that was taken by our social worker, but it was very thorough. The patient identified her preferred language as Spanish. She identified her identification. She was female, identified as heterosexual. In terms of ethnicity, she was born in Venezuela but had been living in the US for about 21 years. She was Catholic. She resided with her partner of 4 years and her uncle, and they rented an apartment in the Bronx. Her support system was limited. She had a prior history of domestic violence. Her current support system was limited to her partner, and the rest of her family and her children remained in Venezuela. When she first presented for care, she was unemployed, but subsequently got a job at McDonald's, even though that did not allow her to pay her rent herself. She was financially supported primarily by her partner. She had emergency Medicaid. And at the start of her treatment, she denied any history of mental health issues, but later on, had expressed feelings of sadness and worries about her cancer care in the future. So our prompts for the audience, and these should also be on your paper, is what potential barriers exist to accessing treatment for this patient, whether she's on standard of care treatment or clinical trial? What resources should we be assessing or would be helpful for your patients at this stage? And do you have any tools in the clinic that would help you to assess for these resources? We're going to give everyone some time to discuss, and then we'll wrap up again.
About 8 minutes?
Yeah, you'll have about 8 minutes. And then if some of the groups can identify someone to come up and share your thoughts, that would be great. All right, if everyone can start wrapping up their discussions, we're actually going to have a couple people out in the audience with microphones.
I don't want to cause a whole craziness. Can of worms. Coercion. No, we talked about
Hey, we have a great comment over here. This
Awesome.
table's has an idea that could open up a whole new can of worms. So yeah, who wants to go?
Hi, I'll stand up. Summer Dudney, I'm a gyne-onc in Chicago, and we've been having a very fascinating conversation. We definitely got outside of any of these questions. And we mostly talked about just our own personal experiences as being providers and patients not showing up to treatment, having lots of transportation issues, it being a really big system issue that it's very difficult to overcome. We talk about trying to get grants for transportation, but we're just doing a lot of cobbling and patching things together, and you succeed with some patients, but then you have to apply for another grant to get more transportation within like 12 months, and this goes on and on. And I was recently at some sort of virtual meeting, I can't remember the details, some months ago, and there was a gentleman that was presenting about pay for clinical trial enrollment, that you would pay patients to enroll in clinical trials. And that was the can of worms that we were just kind of discussing. So I wanted to see if anyone else has any other ideas on that. But, obviously that brings up a lot of questions too. I'll leave it very open there.
Mark Shaheen, Philadelphia, U.S. Oncology now. So I just wanted to say that as somebody who has enrolled a lot of patients over the years, there is an implicit bias in the team when you know that the patient is probably not going to meet the exact requirements of the study throughout the course of the study. You know that they may not be able to get their labs, their upcoming CTs, their various assessments. And then the team begins to have this bias to say, like, why are we putting this patient on trial? She's not a good candidate. And so I don't really know how to overcome that. I know I have that bias. I've tried over time to discourage that sense amongst the group and try to rise above that, come up with resources. But it feels that the system is essentially structured against you wanting to do that. And I think it's a systemic problem, and I guess it starts by first acknowledging that this bias exists in the teams, and right away we basically say, no, she's probably just not a good protocol candidate, and kind of walk away from that. And then we also talked about, like, in this particular case, if a patient goes on a trial, requires daily radiation, how can we actually ensure she shows up for these visits? Because we know in reality many of them skip many of the appointments because of work requirements and transportation issues. And again, and the system evaluates us, right? So we get minor deviations, major deviations when we don't adhere to the clinical trial specified objectives.
Great, and I see Dr. Farley here in the middle.
John Farley, St. Joe's in Phoenix. With our group, very interesting discussion about, number one, a lot of institutions will have support for people who are very impoverished, and obviously people who don't have insurance, or people who do have insurance aren't a problem, but there's kind of a vast middle layer of patients that are just living on subsistence for which the system is hard to navigate. We also found that the social support is sometimes and perhaps more important than economic support, discussing with our patient advocates, just having that social support, being able to navigate the system is vastly important. And then finally, in conjunction with that social support, having an advocate, somebody in the medical system, a physician, or something along those lines, that's in your corner can be essential and can give you a distinct advantage and perhaps an unfair advantage compared to the general population. So,
yeah.
Hi, Joan Walker, Oklahoma. I am the NCORE PI and have a concept to overcome this problem, and we'll hope that it goes nationwide. But we have contracted with a company named Guideway Care. It's a nationwide company for support for patients. They provide a community-based navigator and charge $35 per patient per month. So we've started the EPIC Social Determinants of Health screening tool, and anybody who screens positive gets assigned a navigator. And that navigator helps them not only with their appointments and transportation, food, whatever. I'm hoping that we can get DCP to pay for the enrollment of patients on the NCORE trial, and then Guideway Care is going to pay $50,000 to get the study open and in as many centers. It may be only NCORE first, minority-based NCORE centers, but I'm hoping we can document that patients are more compliant, they're less likely to go to an ER, they're less likely to have emergencies and toxicities, et cetera. So this, hopefully all of you guys will be supportive.
Yeah, thank you. That's excellent, and thank you for working on that. I think that I'm hearing a common theme is, really wanting to help address some of these challenges that our patients face, but not necessarily having the resources ourselves. So any ideas or experiences people have had that could be helpful to others, we're really hoping this will be a forum to share those ideas. I also want to, this may not have been clear at the beginning, but if you write your ideas down on the papers on your table, we are going to combine all of those and redistribute to the group so that everybody will have the resources that others have identified. I see Dr. Pathuri.
Michelle, I just want to make a comment. So I think that every patient is a good patient for clinical trial, and I think that's the mindset that we all need to have. We have to get away from this idea of, oh, they're not going to, this isn't a good patient. Like every patient, should be given that opportunity and the equal ability to participate on a clinical trial. Unless they don't meet the inclusion criteria or exclusion criteria, they are a good trial candidate. And I also want to say that, I just learned recently that CMS is now covering for navigators. So our institutions will be able to hire navigators and be compensated for their work. So this is something that we all need to take advantage of so that we can improve bringing these issues to our patients to be able to handle them in a manner that we feel comfortable with, addressing childcare, addressing transportation, addressing their CT scan visits, addressing their PK schedules, all of these issues where we can have additional resources to help support our patients. Thank you.
Oh, all right. All right, let's go in the back and then we'll come back to the middle here.
Hi, I'm Abigail Zamorano with UT Health in Houston. So my group had a really interesting discussion, mostly about some of the frustrations that we felt in our own attempt to provide the best care for patients, both standard of care and clinical trials, in that we might feel limited by the resources that are available either at our institution or based on where we live, because so many resources for patients are dependent on their city, county, state, and what that group has decided is appropriate for patients to receive. So we did a lot of troubleshooting. There were some recommendations of reaching out to local advocacy organizations that they might have resources for transportation or childcare. And then someone else suggested for our younger patients, even talking to the pediatric groups in the hospital because sometimes they have more resources available. We also talked about who was doing the SDOH screening and how important that was. We talked about adding in discussions of or questions of health literacy and also questions of stress into SDOH screening in order to really understand what kind of needs our patients had. Oh, and legal, yes. Sorry, yes, legal.
Excellent, thank you. Okay, let's go here in the front and then we'll take the last comment in back.
We were discussing at our table the mental health side of this that I think very frequently goes unaddressed or is something that we have difficulty. This is a young woman who doesn't have her children with her, and she has one person. She's mentioned some issues with depression. So how do we address that specifically in a woman that speaks Spanish? I know at the institution that I work at, we have support groups, but we don't have Spanish-speaking support groups. So we have to find ways to also get her mental health evaluation, get her to a PCP that can get her any kind of medication that she might need, therapy. It's great to address the barriers of getting to your appointment and financial barriers, but if the patient just is depressed and doesn't want to do it, they're not going to do it. We can give them all the resources available, but if we don't address the whole patient, then we're not going to move the needle.
Yeah, and I think that's an excellent point, and it's not just language, but also finding culturally appropriate support for our patients. So, all right, in back.
Thank you. Alex Solaway from Pittsburgh. So, I mean, on our table, we focused on language barrier, and we felt that sometimes you're not getting the best interpretation of what you're actually trying to communicate to the patients. And one of our members presented our institution's attempt to mitigate that by training certain people who actually were able to monitor the interpretation being given by the interpreter. And we talked about the fact that the telephone system that most institutions use are not very efficient and probably don't do the job that it's supposed to do. But specific to clinical trials, though, we also mentioned, something was mentioned that was of interest to me, which I never thought about, is do we pay attention to our screen failures? Because it can be interesting to look at when we talk to patients about clinical trials, we are successful in recruiting some. Who are we not being successful in recruiting? Then I have a question for the panelists and the group members here. That is, see, I'm one of the vice chairs in my department, and when I sit at the strategic meetings, I hear all the time about the progress that we're making in the OB world. So like the doula program, and I'm like thinking, so why don't we have a doula in oncology? But I don't know whether there is a specific thing about the doula program that makes it not suitable for oncology, but it's like changing the world in obstetric care. So.
All right, great. Yeah, I think that's a very excellent point that you made at the end. Do we have time for questions?
We have a minute.
We have 1 minute. If anyone has a last burning comment or question. Okay, Dr. Mueller.
Yeah, hi, Carolyn Muller from New Mexico. And I have a question. Do we have a Spanish-speaking patient advocate?
I don't know the answer to that. I see a hand up in the back left there. I don't know if we can get a microphone. I'm hearing that we do on the committee.
Okay. The reason, I mean, I'm in a state that's 50% Hispanic, so this is, I just want to tell an experience because I had to advocate when the NIH was doing their 50th anniversary for clinical trials and had their piece. I had a patient that I had on at least 2, if not 3 clinical trials, completely Spanish speaking, was such an advocate. And I had to almost beg them to have her featured in that. And she was the only Spanish-speaking person that, they put her statement in Spanish and then had it translated. But that was just a tour de force for us to do that. And so, I'm thinking as we're being inclusive, I just wanted to bring that out because, I think that's another group, and as this case showed, that we have a lot of opportunity to harness too, even here.
Yep, I agree.
Just a quick related comment. I chair the Patient Advocate Committee. We actually have 2 Hispanic women on the Patient Advocate Committee at this point, but I would not ignore the fact that there are a lot of other people who are bilingual in this country. I speak Spanish, I speak Portuguese, but I wouldn't be the person to counsel a patient on that, but don't ignore those resources. The other resource I would say is the automatic translation services that you're now getting on multiple platforms are pretty darn good.
Excellent. All right, last comment.
Hi, so I'm a radiation oncologist. I'm also Hispanic and a female, and so this case presentation was kind of right up my alley. This is a patient that was a bread and butter case for us in the Bronx. So I just wanted to say that at our table, we discussed a lot about from the moment the patient comes into the room, having someone like from the MA to the nurse automatically getting the interpreter involved, or having someone from the team speak Spanish, really kind of changes the game for the interaction with the patient. When I speak to my patients in Spanish, they become, it's a world of difference in terms of level of comfort, trust, and being a true team member, and not only care, but considering clinical trials. And then my other comment is that kind of addressing the biases we all have about patients that may have been labeled difficult in the past. A lot of times when you get down on their level, you do things such as speak to them in their own language, really express that you are there to get them the best care needed and you're on their team, and you really validate their concerns and their fears. They oftentimes, partner with you and demonstrate that they can be a non-difficult patient and come for treatments and give, the level of commitment to the care that we want to see. So I think that's really important. And then the last comment from a radiation standpoint, when patients are coming for daily radiation treatments, we have therapists at the machine checking off and software checking that they're coming for each treatment. So if you see somebody's not coming for treatment, that should really trigger a phone call, or maybe even considering putting an alert in the system so that way you can improve your compliance. Thanks.
Oh, do you have a comment?
Yeah, please. Can you hear me? Is that good? Okay. So first of all, the comments everyone's making are just outstanding, and I think they're really important, and they're real, right? They're the real experiences that we have every day. I want to amplify a couple of quick things. Someone spoke about the importance of recognizing the diversity of language, and I think it really is critical that we recognize that, because we have people who are from other countries, beyond this, the Latino, Spanish speaking, which we definitely need to continue that work there, no question. I think it was either amplified also that there are people who are from other countries. We have a strong Hmong population that's growing in Durham, North Carolina. We need to make sure that we're also being able to make sure that those patients can be able to be engaged in a meaningful way as well. If you look at areas like Philadelphia, where we have many different enclaves of populations there, just really thinking about what is it that's important to our community, like when we think about the patients in our area, to really think broadly about, are we meeting the patients where they are in terms of their language, where they live, where they worship, where they play. And I think the last thing I will say is that one of the things that we all probably could think more about, our patient advocate will probably touch into this a little bit too, is the importance of community engagement. I think sometimes as systems we assume that we have got to carry all of that load, and don't get me wrong, we do. We have a huge responsibility, but we can also partner with community organizations to be able to make a difference. So when we're talking about mental health, for example, we have two strong partners with El Centro Hispano. They've been the longest Latino serving organization in Durham and the Greater Triangle area forever. They are amazing, and what's amazing about them is that they actually create support groups for cancer patients. They actually have those retreats that they get funding for, and we work with them to get funding to be able to provide retreats for cancer survivors to go and have that time alone, to engage with others who are like them in their communities. So I think it's important that we not just think that the health system then is going to create retreats and create all of the supports. Sometimes it's collaborating with our partners. And if you're writing a grant, put that partner on your grant so that the partner can be able to provide that part of the engagement and the collective social support and solidarity that's needed. So I just wanted to highlight that, because I think that sometimes we may not necessarily have all the skill sets all the time to be able to actually create that full inclusive environment. And part of us being more inclusive is including our community partners in a more meaningful way.
Great, thank you. We're going to move on to session 2.
Yeah, thank you all for the engagement. It's been incredible, so keep up the good work. So we'll move on to session 2. This session focuses on addressing institutional barriers and addressing advocacy to improve IDEA. I'd like to introduce our 2 moderators for this session, Dana Chase, who is right here. She's an associate professor in the Division of Gynecologic Oncology at the David Geffen School of Medicine at UCLA. Welcome, Dana. and Tara Castellano, I need to say it correctly, who is an assistant professor in the Department of Obstetrics and Gynecology and the section of gynecologic oncology. Welcome, Tara, and I'm going to turn it over to you both to introduce the speakers for this session.
All right, so first up is Dr. John Farley. I had the privilege of working with John in Phoenix, Arizona at St. Joseph's Hospital and Medical Center. He's currently in the Department of Obstetrics and Gynecology, a GYN oncologist with the Dignity Health Medical Group, and also head of GYN oncology at that hospital, and the Cancer Institute at St. Joseph's Hospital and Medical Center, and also a professor at University of Arizona College of Medicine and Creighton, which both have hubs in Phoenix. So welcome, John.
Thank you very much. They're supposed to have a pointer, and they don't. I said, Joe, it's John. I'm gonna walk, okay? You got me? Cool. So I'm gonna try to come down here a little bit, hopefully be a little more interactive, so if I get lost, you'll understand what happens with the slides. You see my honorary there, kind of what we're going to go through. So why are we here this morning discussing what we're discussing in this symposium? I know Dr. Alvarez and Dr. Secord, we could be doing kind of molecular staging and treatment of endometrial cancer. But we tend to feel this subject obviously is very important. Number one, recruiting minorities allows us to be able to generalize results in our clinical trials. Also, as Nadine, Dr. Barrett brought out, the lack of inclusion can cost billions of dollars with regards to research and implementation of drugs within the clinical trial system. Additionally, it can compromise accrual on clinical trials. Lots of trials are shut down for lack of accrual, and it compromises health disparities that are already seen in these populations. So again, this is a very, very important subject. Probably the largest institutional barrier with regards to clinical trials has to do with distrust and mistrust. Distrust is the feeling of an individual that an institution has violated their trust. Mistrust is the feeling that an institution or principal investigator is not acting in their best interest. And for African Americans, this is mainly brought out through the Tuskegee Civil Study. Kimberly's going to talk a lot more about this, but I'm sure everybody's familiar with it and the problems that it has caused. More recently, we've had to deal with the COVID pandemic and the development of vaccines and protocols that have been established. And because a lot of these protocols were developed with not necessarily scientific rigor, in the general population, it has definitely hurt the trust with regards to our institutions and the development of our health care. If you look at the CDC, it generally mandates that children greater than 6 months old should receive a booster shot. However, if you look at France, if you look at England, they don't recommend booster shots. And if you look at India and you look at Germany, they don't recommend getting the COVID vaccination at all for children under 12. As a result of this barrier, less than 20% of children under 12 in the United States have been vaccinated against COVID. So you can see kind of what we're up against with regards to barriers that are already seen. There are some systemic barriers that we'll go over. It's been talked about previously, talk with regards to the research team. We know similar races or like races do better as far as treating like race patients. Here I quote a cardiovascular study in which Black participants and Black investigators were able to reduce the cardiovascular morbidity and mortality by 19% between blacks and whites, and so very important. Investigator bias, implicit bias plays a role. And here we can see an elegant study that was done looking at oncology patients that were coming in for visits and documenting what was discussed during those visits. And as you can see, white patients, more than blacks, had a generally longer appointment with their healthcare provider. And then when you further subdivide that into the research discussion, you can see, again, white patients had a longer time during which research was discussed than their black counterparts. Then, even more elegantly, they broke down the time during the research discussion between blacks and whites. And so, for white patients, again, they discussed the purpose, benefits, risks, and alternatives. And apparently, at looking at that, obviously, black patients are able to tolerate treatments better than white patients because only half the time was spent discussing risks of the trial with black patients compared to whites. The only subject for which blacks dominated with regards to discussion was voluntary participation. And then if you looked at the end of the appointment, only a third of black patients were given written resources with regards to research. Distance plays a barrier. We've talked about that. It's important for institutions to try to innovate, to try to do things such as research vans, as they did in the study in Hawaii, in which participants found this very effective in navigating the clinical trial system. The consent process also can be a problem. Exclusive of the language barrier, it can still be very complicated. And interestingly, the most positive predictor of patients being able to enroll and process a clinical trial is having a primary care physician. The stronger the connection between a primary care physician and the patient, the more likely they are to enroll in clinical trials and complete clinical trials. And as you heard in the previous presentation, this subgroup of patients are less likely to have primary care physicians, so we're starting from behind the 8 ball. Now, looking at academic medical centers, it's important to identify what is the identity of your academic medical center. Are they going to be interested in research, or are they going to be interested in making money? And that comes back to the remuneration model that would be used at your institution. And most institutions go by the relative value units remuneration model. And this actually disincentivizes research because it rewards procedures and surgeries and things along those lines. And so when you're going to your radiology friend to evaluate target lesions in a patient who is on a study, they, number one, have to take time out reading films for which they are getting paid, stop, go over films which they've already read and are not going to get paid for, and discuss them with you. And so, again, this remuneration model necessarily disincentivizes research for clinical trials. So in 2020, during the appropriations process, Congress mandated that the NIH conduct a study on the medical and economic impact of women and minority recruitment into clinical trials. In order to do this, they conducted almost 100 interviews over 5 cancer centers in the United States, in which they interviewed 4 groups of people. They interviewed the cancer center leaders, they interviewed PIs, interviewed the research team, excuse me, and also the referring physicians. And they found initially 3 kind of common themes of problems in this evaluation. Number 1, there were no existing programs to recruit or retain minority participants in clinical trials. Number 2, the participations in clinical trials in general was poor. And number 3, the navigation of clinical trials through the academic medical centers needed to be simplified. And so This group discussed this and came up with solutions. These are the 8 bullet points. I'm going to briefly discuss them, kind of in your handout in your packets and the slides. I go into it in a little bit more depth, and if you want, there's a 300-page treatise that they wrote up following this, if you have some free time to do some reading. So one thing, again, you can do is to budget adequate time, staff, and resources in order to complete the study. And as we talked about, importantly, starting 1 January, CMS has given us the capability to reimburse for patient navigators. And so, again, as you look here, they've given kind of 3 different subsets of areas which they will reimburse. We have the codes here for you. Again, these will be available in your packets so you can go back to your institutions, and you can provide patient navigators, which are greatly important in the process, and hopefully help contribute with Dr. Walker's trial. And so, obviously, these patient navigators, they're auxiliary personnel. The requirements are only that they be trained. They do not have to be from your institution. And you can rent or employ people that are outside your institution if you like. Recognize that trust is fragile with your community, and as everybody has talked about, find ways to go out in your community to establish that trust with your patients and with their communities. Reduce the burden of the clinical trial participation. We've seen some novel ways, some video visits, some home visits that can reduce the burden of patients participating in clinical trials. Make your protocol adaptive. Again, we're going to discuss a little bit more depth, but interview patients as they're going through the clinical trial process. Ask them what can be done to improve their participation in the trial. And then when you're doing that, improve the trial, make the corrections that they have suggested. Identify any elements within the clinical trial which might be motivational to your caregivers within your institution, and provide incentives for them to participate in your clinical trial. Also, try to provide a diverse group of participants within your decision-making bodies and organizations at your institution so they can advocate for minority participation in clinical trials. And then finally, have a diverse and experienced research staff, and as we keep saying, we advocate for implicit bias training for everyone who is a part of your research team. Now, as Dr. Hines said, Allison Felix was a member of the 4x400 relay team. They won 4 Olympics gold medals in a row. And of that participating relay team, of the 4 members, 1 member has died because of hypertensive disease in pregnancy, and Allison Felix almost died because of this disease. And I think it's important, as she said, that we should not have to advocate and be prepared to advocate for ourselves as patients. We need to continue to do a better job as physicians, as enrollers in clinical trial, to make it easier for our patients to come and be treated for us. I'd like to thank Dr. Alvarez, Dr. Secord, again, for recognizing the importance of this subject and allowing us to talk. Dr. Hines, Dr. Porfiry, for allowing me to do this. Thank you.
Can I make a comment? Thank you for that presentation. This is Joan Walker again from Oklahoma. I come from a state where the governor has proclaimed diversity illegal. And my job as the DEI for my cancer center has no state dollars. And so we've changed our name to Belonging and Inclusion, hiding the D word. And we have a horrible distrust in our community because the University of Oklahoma stole the property of the African American community in the northeast section of Oklahoma City, and they've hated us ever since. We are trying a redevelopment plan to try to build back some trust within the community, but that's a painful history. I wanted to comment on the RVUs. We have a system in our institution where enrollment on a clinical trial gives you RVUs. Maybe we need to talk to pathology and radiology and give them credit as well, because they do a lot of work for us. And I do not know if Dr. Mantle has implemented that, but I recommend that you go back to your institution and evaluate the RVU system and make sure that the researchers are getting RVUs for their time and effort. Thank you.
Thank you, Joan. I just wanted to comment. Yeah, I just wanted to follow up on that comment about radiology, and I think there are ways to address that. Within our CTO, what we've done to standardize the process is we've actually put it into our billing grid, and there's not just the CT scan fee, but also the RECIST fee that gets paid to radiology directly. In addition, for IITs and for cooperative group trials, what we've done is we have asked our hospital to help cover that, given the additional revenue that is generated with patients being put on trial. So we have been successful in those ways, so it just depends on how you can negotiate with your center.
Thank you so much. Those are all important topics that we also struggle with at our institution. And thank you, Dr. Farley, for such a great presentation. It's my privilege to present the next speaker. Kimberly Richardson is a two-time cancer survivor and patient advocate and the founder of the nonprofit Black Cancer Coalition. So we're so privileged to have her speak today.
Well, thank you. Hopefully you guys will have ears to hear me after I've sort of scolded you earlier. But honestly, I'm very pleased with the second case review and breakout, and to see the encouragement. I took copious notes. So thank you so very much for opening up and sharing what you were thinking in those breakouts. I really appreciate it. And thank you to everyone who invited me today. I definitely appreciate being here. I do want to disclose that I am speaking from my own personal experience as a patient advocate. So one of the things I think we've already heard and we all understand is there are very important reasons for the lack of diverse representation in clinical trials. And I think since COVID, we have all heard it. We've heard all of the reasons. We've heard about medical mistrust. We've heard about provider bias, and lately we're hearing a little bit about access to trials and even the mismatch that's happening in terms of access. I think over the last 3 to 4 years, though, in my experience as a patient advocate, I've gone to several conferences, I've spoken, I've heard a lot about the research. And it dawned on me at some point in my work that maybe what I should be doing is using that research to teach patients and caregivers and survivors exactly what you get funded to study, and to use that information that you all have already produced to engage people of color around this topic of clinical trials. So here where we start is clearly with these particular issues that particularly have more to do with the Black population. We know already about Lucy and Anakar and Dr. Sims, your father of gynecology. We know about the heinous types of things that were done to these women. And that narrative has been used, so to speak, to
suggests that that's how the Black population sees things. So in many instances and in many spaces, you hear this data that says, we don't trust. What we have learned, however, is it's not that we don't trust, it's that we haven't been asked. Dr. Barnett said that very clearly, right? So, but how as a Black patient advocate do I take information from Henrietta Lacks and Lucy and Anarcha and the Tuskegee experiment and disprove that narrative that we don't trust when we have things that are happening to people like Shalon Irving? Clearly, let's see which things that have happened to her. In all of these cases, many of these women died largely because of complications in their childbirth. When we talk about social determinants of health, we always have the picture of the person who is suffering from some sort of deficit. But in Shalon Irving's situation, she was an epidemiologist at CDC. Still died on the table. Kira Johnson, she spoke 5 languages, raced cars, and loved skydiving. She died at Cedars-Sinai due to bleeding after her C-section. Her husband learned later that her doctor was responsible for the deaths of 3 other women and was only charged with 4 years of probation. Imagine if something more strenuous was done, that death could have been prevented. Tori Bauer, 2023, found dead in her bed undergoing labor. Examiners cited preeclampsia and eclampsia as possible complications. And then Christine Fields, just in 2024, died from a uterine arterial injury from a C-section. As a patient advocate, I don't have to go all the way back to Tuskegee to talk about medical mistrust. It continues to happen. And all that a patient or a resident from a community will see is that this is happening from the doctor's perspective. So we're asking these questions. Are you making assumptions about patients' attributes, their behavior, or communicated symptoms? And are your clinical notes really representative of what that patient encounter looks like? What we're finding in the research, again, these are things that are being funded to be studied. So these are the data and the facts that are driving conversations. You're finding that there are implicit bias in clinical notes in a patient encounter. Right in Chicago, like in 2022, the University of Chicago did a study, and they found that there were negative descriptors in people's clinical notes. Those clinical notes then, of course, make it to electronic health records. Electronic health records are used to find participants in clinical trials. So when you see negative descriptors like angry and non-compliant, I'm wondering whether vendors are going to use those particular patients as likely participants. So I think we need to be, really aware of what those encounters look like, right? We talked a lot about social determinants of health. Even Allison said that we shouldn't necessarily be the advocates, that you all as the providers are the people who are supposed to be giving us that information. I've found over time in my 10 years of doing this work that it's imperative that there is a bi-directional conversation that's happening. I cannot rely on you all to tell me everything I need to know about my disease and about my potential treatment options. I would like to feel that way, but we have funding and data that shows us differently. And so how, as a Black patient advocate, do I go out into the community and have rich and honest discussions about the possibilities of not getting all the information that you need. So I have to give both sides. And I use this data from these studies to talk about this is the reason why it's so important for you to increase your own self-agency in relationship to clinical trials and the treatments options that are being available to you. Again, we talk a lot about access, right? And in Chicago, for example, we have 10 neighborhoods that would be considered medically underserved areas. And they are all within 2 miles of comprehensive cancer centers. So is access our real issue? When a person can literally get on a bus and get to a comprehensive cancer center in Chicago in 10 minutes. So these issues are not just spatial. They go in terms of course, with eligibility requirements, comorbidities, and issues of that nature. But what I have found also is this mismatch. I sit on a gynecological disease team in Chicago, and every month I look at the list of trials and say to myself, who is going to be included in this trial? Why did we take on this particular trial at this academic institution? And why is it still on the books a whole year later? There's been no accrual, and yet we have such a proliferation of mortality rates in uterine cancer, cervical cancer. Why are we not looking specifically at the types of cancer, gynecological cancer, that women and transgender people in our neighborhoods are suffering from? Why are we doing trials that will never accrue the people from our communities? So we all know, again, that the FDA has taken these steps to ensure that there's diverse representation, right? And again, as a patient advocate, I ask myself, well, that's probably going to be somewhere around 5 to 10 years from now. So how do I start to talk to people about being engaged in trials? My work constantly looks at how do we educate people of color about science and about medicine and about the cancer. But how do we then take a group of people who've been doing research one way and get them to be a little less stubborn and talk about the differences between patient engagement and community engagement? And in my experience as a research patient advocate, speaking with scientists and cancer trainees, this tends to be a little bit difficult because this is outside of their lane and it's a little bit uncomfortable. So I wanted to share with you just some background information about the things that I've actually done in terms of strategies. Again, I'll tell you that I'm an ovarian cancer survivor from 2013. I was then again diagnosed with a benign thyroid cancer, but again, the NCCN guidelines change every Tuesday, so I could have been malignant at that point, but they chose to call it benign. But then in the midst of COVID, I was diagnosed with triple positive breast cancer. And in each one of those situations, I still encountered some levels of implicit bias. My background in terms of social determinants of health, I guess people would look at me and make some assumptions, but prior to my diagnosis, I was an urban planner, I ran a non-for-profit, and I was an adjunct professor at Northwestern University and the University of Illinois at Chicago, and I taught about urban planning and urban policy. When I went in, of course, as a person that was diagnosed, those things didn't matter, right? Having these kinds of conversations with my gynecological oncologist, I was not shy about research, and so of course I brought in all my PubMed articles and said, did you know that this is happening with granulosa cell tumor? Could you tell me a little bit more about this? And I was shut down. I was literally told, just do what we tell you. Asking questions prompted me to get into this level of advocacy because I thought to myself, if I'm one of the smarter, crayons in the box, what's happening to the cashier at the gas station with no HR to back her up in terms of understanding what qualifies for her treatment? What is she learning when she walks into a healthcare system? Does she understand the steps that she's supposed to take? And over the decade, I've found through support groups that it's disparaging information amongst patients. When you get the chance to talk to them, they'll say, well, nobody told me about X, or when was that supposed to happen? Is that something that I can go back and ask my gynecological oncologist about, right? I didn't know I was supposed to get this type of treatment. I didn't know my treatment was supposed to be that long. And so you're starting to see these disparities even within the support groups. And so to encourage more women and more transgendered people and caregivers to get involved in advocacy so we can level that playing field. So I just want to give you a few examples of the types of things that's possible to do with patient advocates. This is just a little rundown of what I've been doing with my time over the last decade. I got involved in UPATI because I thought it was important to find out what people are doing globally in terms of patient advocacy. I sit on the PCORI's Board of Governors. I am a public member of ACGME, the Emergency Medicine Review Committee, and I find that work very challenging, talking to emergency medicine doctors who are godlike in their thinking. To talk more about how we can get gynecological symptoms on their differentials. I am the chair of the Illinois Comprehensive Cancer Control Plan. I sit on its diagnostic, treatment, and survivorship program. And then lastly, I am now the chair of the Illinois Special Commission on Gynecological Cancer. And that is the truest labor of love for me because I actually developed that resolution and got it through the state's General Assembly. This is a picture of when I first got started. It's clearly just a picture of a bunch of cancer survivors going to a lab for a field day. And what I found in that experience, not only were the survivors asking questions like, how do you sit in this lab and do this over and over and over again, getting the same results and failing and not getting what you wanted to know about cancer and cancer pathways. And these cancer trainees were sharing their stories of, I'm in this because my grandmother had ovarian cancer. I'm in this because someone I know died from a gynecological cancer. But the gentleman that's standing right in front of me, if you can see me in that picture, as we were leaving said, how can we do more to relate to survivors? We sit in these labs and we don't get a chance to talk to any survivors or anybody in relationship to the work that we do all day, every day. So I developed this thing called the Survivors Advising Scientists Educational Program. And this was only because of the leadership at the University of Illinois, Chicago, that this even happened, to tell the truth. But what we did was it was a bidirectional kind of process where we asked the cancer trainees to develop educational content on what is cancer, what is ovarian cancer, what are the different treatment options. And then we gave that educational content to patient advocates. And I said, guys, write this stuff in easy to understand language. And they were like, oh, we got it, no problem. We gave it to the patient advocates and they were like, what is this? It doesn't even make sense. And so it was a lot of feedback that went back and forth. And what happened through that process was a true respect for what each does in terms of advocacy as well as cancer trainees. I am almost certain that those trainees are going to become the types of researchers that I'm going to truly be proud of as it relates to engagement. This is just a few of the modules that we did back in 2019. And it was a pleasure to do this kind of work, to really break down what it is that's involved in research so that the average person, a patient, a survivor, a caregiver, can understand this language. And so I've moved from this kind of easy to understand educational information to taking it in and being my own co-PI. And I got an opportunity again with the University of Chicago, one of a gynecological oncologist there, where we were able to just sit down and do listening sessions with Black and Latina women who have been diagnosed or currently in treatment to get their perspectives on what is the patient encounter, what types of communication issues are you experiencing, and what do you truly understand about your cancer and your particular treatment options. The second type of thing that I've been involved in is now as a co-PI at Northwestern in Chicago. And this is with Dr. Dario Roque. I've gotten this rich opportunity to train survivors and community health workers, both Black and Latina, on gynecological cancer, on clinical trials, on inclusion and exclusion criteria. So we really delve into, are these comorbidities really enough to keep somebody out of a clinical trial? And that Impact Chicago program has now trained community health workers to actually go into those dark spaces of clinicaltrials.gov and to be able to assess when they are meeting residents who have been diagnosed with a gynecological cancer. They can immediately tell them what trials are available in the city of Chicago. The other few things that I'm involved with is, that I'd like to talk about a little bit, is the Kaiser Permanente study, which is led by Dr. Alyssa Bandera. This is another opportunity for patient advocates to be on external advisory boards. In many instances, what we find as patient advocates, you ask us to be on these committees, but you only really want to hear about our lived experience. They're like, share your cancer story, right? But what you're missing in the cancer story are those little nuggets that help you design research. When you hear us say things about our toxicity load in our treatment plans, that ought to ring a bell in your ear about, is my design is it putting too much of a pressure on the patient to come in 3 times a week to extend all of this toxicity and all of these patient burdens? I mean, it's a lot of things that you can think about when you're listening to cancer stories as opposed to the proverbial head nod and going, that was so inspiring. We're glad to be alive, get it, trust us. But what we really want to convey to you is the importance of how important our shared story, our lived experience is to medicine and to science. The last thing I really want to explain to you all about is our community health worker training that is now expanding in the city of Chicago. I am so pleased to have been able to train this group of people. What we were able to do through the Foundations of Women of Cancer who supported this project, again, not something that comes from an advocate, but it has to come from leadership, the people in this room, and leadership from foundations as well. And Dr. Gardner has, I know if she's in this room, she has supported this project 100%. We train community health workers on gynecological cancer and on the importance of being involved in clinical trials. The assumption I had is the simple one, that even though they are community health workers, they do not have a specialty understanding about diseases. And so what ended up happening was when we explained, we being gynecological oncologists in the city of Chicago, as well as gynecological researchers, in easy to understand language to these community health workers, what we found in that instance was a connection of both females and transgender people around, you know what, I didn't even know this kind of information. And so what we did from that training, we offered them the opportunity to invite family and friends to hear their presentations, that now they're Foundation for Women Cancer ambassadors, and they go out and they move the message around gynecological cancer. And what we found in those family and friends presentations was a safe space to talk about what people don't know. And it helps to enrich how we come back to the table and explain even more about gynecological cancer. And so I want to end basically by saying it's really important that patient advocates can be trained as well to learn to speak your language, to go beyond their lived experience, to be able to connect with the medicine as well as with the science. But it's your job to bring that information to us in an easy to understand language so that we can advocate for you, so that we can talk about, yeah, there are these issues with mistrust, but how can I create some self-agency in you so that when you do encounter your provider, you all are talking to each other and coming up with shared decision-making that's really going to impact your life. So I thank you for your time.
Thank you so much. And we just have time for 1 or 2 questions before we go on to break. Dr. Walker?
Kimberly, can we clone you?
Seriously.
I am so impressed, and I lead a African American advisory board at NOU, and I have been trying to do what you're talking about, and I'm not doing a very good job. Do you have curriculum for your community health workers? Do you have something that's taped, something we can take and move nationally? That's just phenomenal and so desperately needed.
Is this on? Everybody can hear me? Yeah, I think that, of course, we have that educational content. Again, what I want to stress is that it has to have, ears to hear. People have to have ears to hear it. I think in my experience in this last decade of pushing and trying to get medical providers and researchers to understand the importance of engagement and understanding the difference between patient engagement and community engagement and all of the issues that we know. So yes, I think it's very important. I created this Black Cancer Collaborative non-for-profit to do just that, but it does lend itself more to creating capacity building for residents. I end up doing a lot of collaborative work with researchers and with medical providers. And so I'm happy to talk to anyone who's really interested in how do you reach your patient in a very meaningful way. So yeah, I'd be happy to talk with anyone who wants that information.
And to that end, we did create a PowerPoint slides of all the links from everyone's talk with those resources, and I had some of Kimberly's resources and links in that slide that we'll distribute at the end of the symposium.
So I have a passion for health literacy and the understanding of symptoms. I fear that nobody knows what postmenopausal bleeding is. That's just the bane of my existence. I have patients who've been 5 years of postmenopausal bleeding before they present. And so I would love to nationalize your program with symptom education for our population and take it to junior high and high schools as well as adults to try to help them to educate their parents.
Listen, I have patients who have presented with abnormal bleeding, who have come repeatedly to emergency rooms that they use basically as their clinic. Mm-hmm. And they go home with Tylenol and a note that says, see your primary. And then this is a person who then eventually gets stage 3, stage 4 of a gynecological cancer. So as my work on ACGME is to get them to see that and to build in educational curriculum that we start tracking metrics that says, how many times has this person been in this ER before we take some responsibility for an ultrasound to get a little bit more information and more a little bit more clarity about what we would be able to do for this patient.
Thank you so much. And we have some more questions behind you.
Thank you so much, Mrs. Richardson, for your talk. My question had been around the long-term game, especially with educating starting in middle school and high school, and just wondering if there's any programs. I'm just coming up for ARM fellowship, and so one of my hopes is, as an attending, being able to start there and figuring out the best way to be in the schools, because I think if we're going to really see a change, even bringing middle schoolers and high schoolers just to see what even a lab looks like, or see what clinical trials even means broadly, so that it's not such a surprise and shock when you're digesting cancer and then having to digest clinical trials and digest even the medical system. And so I think there's just such an opportunity to start at such a young age. I have 2 young daughters, and they understand what a vulva is already. And so just trying to start from such a younger age.
Well, thank you for that. I actually have a program that I've coined Family to Bench. And I'm continuing to trying to get this kind of information funded. I think that a lot of academic institutions do have sort of those career track programs where they either work with elementary school students, high school students, the whole STEM issue. But what I really want to get to is inside the home. I want gynecological cancer to be just as knowledgeable as COVID, whether we had the wrong impressions of COVID or no, every household understood something about COVID. What I'm attempting to do is get us past those secrets that kill, right? That you're sitting there, you know grandma died from cancer, but you don't know what body part it was, right? And no one else does. And we haven't had a conversation about it. And yet we need to be talking to a simple thing that a provider could do is a telehealth visit with the entire family once somebody's been diagnosed. Your grandmother now has ovarian cancer. What does that mean for everyone on this screen? How can we help you get in for your testing? Now that she's been diagnosed, where can we get you the genetic testing and genetic counseling that's necessary? When that's done by the provider in a telehealth visit that everybody could sit in on at the kitchen table, that's immediate trust of that provider, that not only they care about that person's grandmother, but they care about our family. A simple gesture.
Thank you guys so much. And we just have 1 minute left, and we're going to give you so many new jobs.
just 1 minute then. I'm Ginger Gardner, and from the Foundation for Women's Cancer. Kimberly, thank you. Thank you, thank you, thank you for your partnership, for your leadership, for being you. I just want to thank Dr. Joan Walker, who's been a leader in our field for many years, and who we are very much appreciative for all of your incredible contributions to our field in gynecologic oncology. And you said it exactly right, we want to clone you, and that is exactly where we are going from the Foundation for Women's Cancer, is to expand our community health worker program and to bring this into other communities. And I think, Kimberly, it was about 6 months from when you and I sat down together and had a conversation to go live, and let's just make this happen. So thank you. I also wanted to give a shout out on behalf of the FWC that there are free patient education resources, fact sheets about symptom recognition, anatomy, basics, how to find a gynecologic oncologist that are free and in multiple languages, English, Spanish, Mandarin, and those are all free. So for those that don't live in Kimberly's catchment area or the next geography we go to, that those are existing resources to help maximize awareness and outreach for all. Thank you.
Thank you, Dr. Gardner. Thank you all, and I think we're ready for a break.
Yeah, so I just want to make one last comment. So luckily, the FDORA Act has now been signed, and the diversity plans are now mandated for any phase 3 clinical trial. And I will tell you, they are happening, Kimberly. But your point is really well taken, because that is only for phase 3 trials. It does not mean it's happening for phase 1, phase 2. And those early trials are really important, where we have appropriate representation. Otherwise, we will not see efficacy. We won't see those signals. And this inequity will continue. So I think I just wanted to highlight that. I want to thank everyone for this incredible engagement. I will give you a break. You will have a 10-minute coffee break, and then we'll see you back here at 10:40.
So as we get started, I have the privilege of introducing our 2 moderators for session number 3. I begin first with Amanda Jackson, who's an associate professor and director of gynecologic oncology and vice chair of gynecology at University of Cincinnati College of Medicine, and also Ana Turgas, who's an assistant professor, Department of Surgery, Division of Gynecologic Oncology and Population Sciences, and the Division of Health Equities at the City of Hope Comprehensive Cancer Center. Please help me welcome Amanda and Anna.
Thanks very much, Dr. Hines, for the introduction. Welcome everyone back to the second half of our session, and I'm sure it's going to be just as riveting and a robust discussions about very important topics. So I have the pleasure of introducing our speakers for this session. First, we have Dr. Roisin O'Carroll. She is the Research Director of the Gynecologic Medical Oncology Service and the Section Head for Solid Tumor Malignancies at Memorial Sloan Kettering. And she's going to speak to us about the very important topic of eliminating disparities in careful protocol design. Thank you very much.
Hey everyone, can we pull up my slide? I think we're just waiting. Here we go. And this way I get out of the bright lights and get to talk a little bit more to all of you. So these are my disclosures. And what I'm going to focus on is how important it is that everything that we do in clinical research is patient-focused, and that the voice of the patient is truly heard. And I think this is a great opportunity today at this symposium to really focus on those efforts and to make sure that those are incorporated, and that for all of us who work at different groups, that we're able to bring that feedback back to our own academic centers, our community settings, and also to our organizations. And why is it so important? Well, we know merely the participation in a clinical trial can have survival benefit for patients. So in this study presented by Morton et al. Last year at SGO, they showed a 3-month survival benefit for patients who participated in a clinical trial versus those who did not in the platinum-resistant ovarian cancer setting. And alarmingly, what we have seen over time is that our trials have become more and more complex. And what we need to do is have a complete paradigm shift towards one of inclusion, and to move away from our historic exclusionary protocols. I loved the way Dr. Bethuri said that, the basis should be every patient is a great trial candidate. Why not? Why not have that as our default and not always just think of excuses of why a patient can't? We should be able to make it sure that every single patient has the opportunity to be able to participate, as everyone deserves the opportunity to be able to gain the same type of benefits. Unfortunately, over time, we have seen a linear increase in the proportion of studies in gynecologic cancers that have had exclusion criteria that are focusing on mental health and social situations. And these have increased linearly over time. You can see these are 2 trials here, where you can see that a patient from a lower socioeconomic group might be disadvantaged, as well as those, for example, who live in a rural setting also won't have the same type of access to a trial. Also alarmingly, at the same time period, we have seen the increased cost of payments for the individual patient in terms of out-of-pocket expenses, very large deductibles, and also for those patients who maybe do have access to less than ideal insurance coverage. We know that the insurance plans accessible to the underrepresented population can be particularly restrictive in terms of the list of network providers, so that further limits the patient's access to clinical trial participation. Historically, the rationale for designing clinical trials the way we did was that we wanted a homogeneous group of patients, and the idea behind this was that you would improve the safety of your trial by excluding patients that you were worried would be at the greatest risk of adverse events, and also excluding patients who were unlikely to derive benefit from the study. The huge downside, and what we clearly see, and a need to modernize criteria, is that these studies were overly restrictive, they have inflexible trial designs, they are not inclusive. There's exclusion of patients with multiple comorbidities, and this may then disenfranchise certain populations, such as, for example, increased prevalence of diabetes in back patients. And so we may unintentionally be excluding patients that we really, truly want to learn about. Also, it leads to increased complexity and cost of the trials, and increase the huge timelines for our studies. So it takes us so long to get an answer, and by the time we're finished doing the studies, we've already moved on, and you know, the relevance is really not as great. And then, of course, how do we address the accessibility barriers? How do we move from a culture of just a select few being able to participate in clinical trials to truly incorporating it into great clinical care? And instead of thinking clinical research as an extra, thinking that this should be a component of every single thing that we do, and it should be standard of care. So the downside has been that we have decreased generalizability of our results. We have lost huge opportunities to gain knowledge, novel insights, and the opportunity for biomedical innovations. And so what we hope to do, and I hope here to discuss some of the barriers and potentially propose some methods that we can to address these, is have the patient at the center, move towards inclusion, avoid exclusion. So in terms of our eligibility criteria, something very basic, we need to be able to justify each and every single inclusion and exclusion criteria with a scientific basis. Not just merely copy forward from our last protocol, but truly think about the drug or the study drug that the intervention that we're doing, and how can we make sure that we're as inclusive as possible. We also have to be very cognizant of normal ethnic variations, such as when we're thinking about neutropenia. We can't forget that there are different cutoffs for different populations, and such as benign ethnic neutropenia, that patient be at no greater risk for toxicity. So what we want to ultimately move is towards highly inclusive trials that don't sacrifice the key endpoints. So there have been a lot of efforts over the last 7 years to address this. The ASCO Friends have published several guidelines addressing different eligibility criteria. For example, traditionally we had excluded patients with brain metastases. We're now really trying to make sure that these patients can have an opportunity to participate in our trials. There are now guidelines regarding HIV and patients with comorbidities and organ function. And 2 years ago, they published newer guidelines that I think were really helpful in terms of justifying washout periods, not just automatically excluding all con meds, and really just very carefully and scientifically thinking about all these. Also, what about the number of priors? Is there really, truly a justification for limiting the number of prior treatments or mandating certain prior treatments that maybe the patient wouldn't have had access to? And thinking about our reference labs, what our cutoff values is, intervals, making patients redo screening tests that may not be fruitful for the patient, and also allowing our frailer patients to have the opportunity to participate in a trial. So NRG over the last few years has made concerted efforts to use these updated criteria and really moved towards one of inclusion. And all our newer trials now are really making a concerted effort to adopt these new criteria. But it's very clear that a lot more work has to be done in this regard, and it's something that we can all work on together. And I think we've heard some great discussion today already regarding other potential changes that we can make to our inclusion criteria. So the next thing is the clinical protocol itself. How do we maximize the patient's convenience? We shouldn't be thinking about like what's best for our endpoint. Is ultimately what's best for our endpoint is how do we get our patients to be able to engage in the study and be successfully treated on the study and be able to follow those patients, and how can we best support the patient? So just simple things like if a visit isn't necessary, don't have the visit in the first place. If you can coordinate different tests and assessments on a particular day, please do that. If we can use local labs instead of using central labs, if we can increase the windows for different studies, if we can ship the drug to the patient's home, if we can leverage telemedicine, these are all opportunities that we can have to improve, and we can incorporate them and actively think about these as we're designing our clinical protocols. So these are just a list of some of the ways that we can work on this. And I think the main thing is just really making sure that all our patients, both at the academic centers, but also thinking about the patients in the community center, so that they have the opportunity. We can take the burden off the smaller community practices by centralizing some of the research administration tasks and taking that huge big burden off them and trying to really facilitate a patient being able to participate in a trial close to their home, and therefore hopefully alleviating some of the access barriers that we have encountered. In terms of the trial design itself, what we really would love to do is modernize trial and use real-time adaptive design so that we can better enrich for specific subgroups. Maybe perhaps we'll scientifically have an idea that there might be a hypothesis that there may be a particular subgroup who are likely to benefit. So we could proactively enrich for that, but then also save patients from ineffective treatment by including futility analysis in that. And from the early stage, when we're designing and developing our drugs, why not make sure that we characterize metabolism and clearly very early on in the drug development for all the populations, so those with impaired renal function, those with baseline organ dysfunction, just trying to do that very, very early on so that when we're starting our phase 1, 2, 3 studies, that we already have those insights, and perhaps we may need to adjust the dosing cycle, perhaps we will need to incorporate parallel cohorts, but trying to proactively address this so that we're not excluding people from the get-go. And so this is what it might look like, an adaptive design where we're truly enriching for those patient characteristics that we think are the best, most likely to respond to our treatment. And also addressing those who are underrepresented, have actively done, like we heard today, you may pausing your study and also then looking at those individuals, engaging with the community and making sure that we're able to incorporate those patients and that we gain that insight for the benefit of all. And finally, in terms of expanded eligibility cohorts, traditionally we've always excluded those higher-risk patients, but why can't we include them? Why can't we have a proactive way to include another cohort or a parallel cohort in our studies with a less restricted or a very expanded inclusive eligibility? You can look at your primary endpoint in that very restricted eligibility, but then when you're doing your secondary analysis, you can basically have a real-world population, and you already have that data waiting for you. We don't have to wait for the phase 3 to be completed and then go out to the real world. We've already gained a lot of that information. And for our patient safety as well, we're also then not unnecessarily going to expose people to toxicity. So what we can look here is like a hierarchical testing and in the intent to treat population. So we could do initially the primary analysis in the very restricted eligibility, but then do our subsequent analysis in that group with the restricted, but as well as those with the broader. And that really will get a comprehensive vision of how the drug works and how it will act in the real world. We can expand our eligibility. Don't just automatically exclude patients with significant comorbidities, frailer patients, those with numerous prior therapies. And we can really make a big effort, in particular in GYN cancers. We really need to look at that unmet need of aggressive tumor biology, the carcinosarcomas, patients with platinum refractory disease, patients who present with brain metastases, really giving them an opportunity so that we can benefit everybody. Finally, I would say the patient voice has to be at the center. It is so important that that's where our focus is in every single step that we do, from the informed consent. We already heard today great initiatives to provide non-English speaking, but what about those who are hard of hearing or visually impaired? It's not just in terms of language barriers, there are also other social barriers, leveraging the community, patient-friendly materials. And there's great initiatives already in terms of the patient perspective. We have the ongoing PROMOTE study, and I would encourage you all to refer your patients to this study. It'll be in the meeting materials afterwards. And this is a great initiative to truly hear what's important to the patient, not necessarily what we think that they think is important, but what actually is important to the patient. And then we can take steps to incorporate that information into our future trial design. Community and patient advocacy engagement. I cannot overemphasize how important it is to have the patient at the center of everything we do. Focus on their wishes in terms of recruitment, enrollment. Don't design your phase 1 study without hearing that patient voice from the get-go. This is something that we should not be just including as an afterthought of the phase 3. This is a patient's voice should be heard from the beginning, and it should be incorporated along the whole way. We have a great opportunity when we enroll a diverse population to gain scientific knowledge regarding germline and somatic variants in diverse population, and then providing that information back to the community so that they as a whole can benefit. And Energy has also tried to include diversity chairs on a lot of our newer studies, and I think this is really a great opportunity to make sure that we're all refocused on how important the patient voice and inclusion is. And finally, a concept that's a little bit newer to me is this return of value. What's in it for the patient? That is so important. What is in it for the individual patient? How will they benefit? We can think of this in terms of remuneration, both monetary and non-monetary. Obviously, ethically, we don't want to coerce anyone into enrolling in a trial. But is it ethical not to fairly compensate a patient for participating in a trial if it is disenfranchising them and maybe making them lose time from work and perhaps even job security? So these are things that we actually have to take really seriously, and we have to be fair and do compensate our patients for the efforts that they put in. There's of course and something I do in my own practice is I'm now trying to give back the patients the clinical trial results, the results that they participated in, but that shouldn't be on an individual basis. That should automatically be done. We should have it built in our protocols that automatically our patients get the results. Ideally, they're individual study results if that's applicable. But why not? Why can we not engage our communities better? And why can't we systematically ensure that we return the results of those clinical trials to them? We need to create a trust in the research. And we all are here in the room are clearly very dedicated to this, but we have to show and be able to extend that trust and for the community to feel that we really are trustworthy. And by that, it is important that we're open, we're honest, and that we do, even our negative trials, that we give that feedback back. It's been very clear that different groups value different things. So for example, in the Black community has been shown that information regarding genetic ancestry can be particularly important. So if that's the case, then that's information that we should absolutely be collecting and we should be giving back. Others have said how important they feel that connection with others, so the opportunity to participate perhaps in a study community where they can connect with others who are on the trial. So in summary, I think there are great efforts and great opportunities for us to move towards a paradigm shift towards inclusion. So in future, we'll be talking about like every single patient should defaulted be offered a clinical trial. That should be our default. And the patient and every single patient must remain at the center of all our clinical trial design. Thank you.
Thank you. That was amazing. Thank you for your leadership in this, please. Do you think we should go to the CIRB and the FDA and ask about reimbursement for expenses when someone takes on a clinical trial?
Yes.
So who do you think in this group should be the person who does that, I guess?
I think that is, yeah, I 100%, I think this is, as I was going and creating these slides, that's exactly what I was thinking about. There are so many obstacles to benefiting the patient. We're so cautious and aware of not coercing people into doing things that I think we're just not as aware of the impact on the individual patient. I saw a patient in clinic yesterday and she started crying because her participating in my trial, she's the primary carer for a 90-year-old father. And those kind of things, like it's going to be such a huge big deal for her participating, not just for her, but for her family as well. And how can we support patients? It's fine, we can send a social worker, but that's like you said, we need, it was said elsewhere that we need the scaffolding in place. We can't just do it on a haphazard way. We need to have a really concrete default of this is the support, this is how you access it, so that we're not all kind of guessing and recreating. And absolutely, it should come from a legislative and a very high level to support our patients.
And NRG does plan and hasn't, but is working on results notification process. So it'll be on the website. You'll have a flyer that will be able to be mailed to the patient. It has to be done at the institution by the research staff. So there's a lot of barriers to actually getting it implemented, but it is in the works.
And patients are so appreciative of that.
Dorothy Erlanger, Chair of Patient Advocate Committee. First of all, we do have, and I think that most people here know from our committees, we do have at least one patient advocate on each of the committees, and sometimes two, and sometimes some general members as well. Could that voice be improved? I'm sure. I loved what you did in terms of breaking down how do you make more people eligible, how do you break down the barriers. That was a great summary of what can be done. And as Joan said, stole my fire, one of the things we'll be doing in our committee meeting today is have a report back on that report of results project.
Great.
Because that has come up in our conversations, and it is important. It's an incentive.
Thanks, Dorothy. And thanks to your committee for all the work. I mean, I know in our committee we really value our patient advocate input, so thank you.
We have time for one more?
Sure.
So that's a great summary and a lot of really important initiatives. And I'm just wondering, since we've periodically brought up these points during concept review and development about expanded accrual, having appropriate, allowances for that, they tend to get shot down following review at the level of the sponsors, the National Cancer Institute or industry. What's the avenue to harmonize better with our reviewers so that we can do these things?
I think we all have to agree together that this is something we're going to do. It can't be just an individual. You're right. It has to be this has to be the accepted default.
So is that discussion taking place with NCI?
That's something that we're hoping to definitely start. I mean, yes, these discussions have been had, but I think we need a more formal.
Yeah, we can't keep competing. Yeah,
I agree, and I think buy-in from our industry colleagues as well. And all of us can, when we're at the different advisory committees and things like that, do make sure that it's as inclusive, and that's something that we've been trying to do, and I've noticed that for a lot of different meetings and interactions that there is now a big effort towards one of inclusion, and even just mentioning the various resources. Often the pharmaceutical companies just honestly aren't aware either. It's not high, they don't realize it's something that should be higher in the radar, and if it's important to us.
They do worry about the cost.
They worry about the cost, but I mean, also the generalization, like a lot of these drugs will come into the
As we get more successful with the Partners Program and working with industry, we ought to have a list of requirements that would include some of these things to help drive it. But thank you.
Yeah, I love that idea.
Yeah, Michael, I think you're right. I think the accountability piece is critical, and statements are important, but acting and operationalizing on those statements will be critical. So thank you.
So thank you so much for such a thought-provoking talk. Excellent concrete steps we can take to eliminating disparities in our clinical trial enrollment. So next we have Dr. McCormick, and she is an associate professor at the Division of GYN Oncology at University of New Mexico. She's also the lead of the Gynecologic Cancer Working Group for Clinical Trials. She's going to speak today about clinical trial implementation.
And I'm also going to head down there because I'm short and can't see from here. Actually, I think I'm okay. All right. So we have heard a lot of things today about all of the importance of this work and about how much it matters, and everybody comes out fired up. But some of these things are things that need to change on a national level. Some of these are things that need to change on a hospital-wide or a community level, all of which can be somewhat daunting, sometimes feels completely overwhelming. And I'm here to talk about things that you can do, ways that you can change your research programs at your institutions, ways that you can make changes so that we can kind of implement this from the ground floor. So when you go home and you say, hey, yeah, I really do need to have a reset for my research program. I really do need to make sure that we're implementing all of these things to make our research programs more inclusive. What are steps that you concretely can take kind of through your research program? And I'd say the first thing is to really recharge, take a reboot, and think about what's your why. So all of the things that we've heard today, all of the things that we know as clinical trialists, clinical researchers, that clinical trials improve these options for our patients. It increases access to trial. It helps move the science forward. It helps us individually as practitioners keep on top of what's coming up. It's much easier to manage side effects down the road if you remember what you did on the clinical trials when you had that nice little step-by-step guideline for how to manage your AEs. And it really elevates the quality of your care. And as we've heard over and over today, it's really important that we increase the applicability of science for all of our patients. So sitting down and bringing this message back to your clinical trials group so that we can really all focus on that why. One way to kind of then sit down and reflect and kind of figure out how you can move forward is to do research optimized site questions through ASCO. So ASCO ACC has this kind of lens, this 4, and I've added a 5th, ways to kind of really reflect on how you can make sure that your trial program is both increasing access to clinical trials for everything, and specifically through a diversity lens. So are trials available? Are patients screened systematically? Are patients eligible? Are patients asked? And importantly then, are patients supported? So go kind of through each of these and think about ways that you and your research staff can kind of optimize those. So it's important to start with strategically selecting trials. So think about what you see the most of. It doesn't do any good to have a bunch of platinum-resistant ovarian cancer trials if what you're seeing is frontline advanced metastatic endometrial cancer trials, patients. So you need to kind of look at your site and say, what am I seeing? What are we seeing here? Are we unfortunately seeing a lot of young women with advanced cervix cancer? Then that's what we need to focus on. And then also, what clinical questions do you need answers to? What are the times that you are going into a patient's room the most, saying, gosh, I wish I had something else to offer here, or I'm not sure what to do? And that's going to be different for each site, but really focusing on what you and your program's needs are, your patients' needs are going to help increase enrollment and access. So again, developing a targeted, thoughtful portfolio really helps you hit a critical tipping point, because once you are able to successfully enroll, then that kind of creates this positive energy and kind of increases the overall enrollment. It's also important, as we've been talking today, about ways to decrease that energy of activation. If we think back to like our organic chemistry days, that kind of energy of activation, you want to really decrease that for your patients. You want to decrease as many barriers. These are patients that often have more social determinants of health going against them. Transportation issues. If your clinical trials are only available at a centralized site that increases transportation barriers, you're going to lose patients and going to decrease access. So really thinking wherever you can I increase my access? Can I make sure that our outlying clinics are able to provide these trials? And then most importantly, so if you think of nothing else after my discussion today, this is the most important point. You want to set up a systematic, organized screening process. My husband says that I'm going to have systematic and organized process on my gravestone, but systematic, organized screening process. So you really want this for 2 reasons. One is it's going to increase your overall trial enrollment. And 2, it's going to get rid of, or at least decrease, the implicit bias problems that we've talked about. So you want this to be thoughtless and automatic, not the doctor sitting there, because we've probably all had the experience where it's 10:30 on a Friday night and you're still dictating and you're going through your assessment and plan and you're saying, gosh, she would have been eligible for this trial. Now you're like, darn it, it's 10:15 at night on this Friday. I can't call her and ask her if she wants to be in that trial. You want to have that in front of you at all times. So you really want to have this not be a burden on your physicians to be the only ones who are remembering when they're having conversations with patients. It's going to increase the number of patients that you pick up, so increasing your overall trial enrollment, and then most importantly for this topic, it also decreases those implicit biases, because then you say, oh yeah, this patient is eligible, and it helps us then reflect back on why we might have not thought of that for that patient. So really very important to set up a systematic, organized screening fashion, and this doesn't have to be some sort of crazy complex AI system or having your clinical trials staff go through every single note on every patient. It can be as simple as putting your clinical trials staff on the speakerphone while you're going through your patient list in the morning, or empowering your MA with an all-important highlighter to go through and say, who are the patients who are a new diagnosis, a new recurrence, or a new progression, so that then that can get sent to the clinical trials folks to screen for clinic. Whatever works for you, but it's important to set up something that's systematic. So then looking at patient eligibility, we've already heard from Roisin that eligibility is something that can also come from the clinical trial sponsors, from our groups, but as a provider, as the physician, it's important to kind of think one step ahead and make sure that we're preserving eligibility for our patients, and to always think about research first. There's always going to be weekly Taxol down the line. There's always going to be Doxil, so you want to kind of think about these access for your patients. And then importantly, it is on us as the clinical trials representatives at our sites to ensure that we have consents in the languages that are used frequently, because it's so frustrating to have a patient that you would otherwise be eligible to enroll and realize you don't have the Spanish language consents yet. So then the other one is, are patients asked? And we've already talked about this. If you set up a systematic, organized screening process, then that's going to make it flag in your mind, and that's going to prompt you to ask all of your patients rather than just kind of the ones that you have as a vision of who you would want to ask. Then I'm going to kind of go against that, where I said this needs to be thoughtless and you need your doctors not to think about it. In actuality, you also, on top of that, need to have your doctors thinking about it. So really, everything that you can do to create and foster a kind of healthy, competitive situation where doctors and all of your providers have this culture that research is important. And there are lots of different ways to do that. So like we talked about, a critical mass of trials, making sure that you have trials that are available for your patients, for what you see in your research center, because it's frustrating for providers to continually say, oh, I don't have a trial for that, I don't have a trial for that. Eventually people are going to stop asking whether they have a trial for that. It's then also a simple move, but a way to provide accessible, timely trials information so that your providers, your doctors don't need to be sitting there saying, I think there was a trial, but there were lots of numbers. What was it, right? So instead having a list that is accessible by disease site so that your providers say, oh, hey, I've got somebody who's got recurrent endometrial cancer. Let me see. What do I have for that? Ooh, I've got that. Actually, she would be eligible for that. So you want to have multiple redundant ways in which you can catch patients for trials and make sure that your providers can see, your doctors can see what is available. And then this is how I've organized it, whatever you want, but you can do kind of the trial name, the question, so that doctors can see easily, all the nurses, everybody can see what the question is, and then what the arms are so that your physicians feel empowered, besides just the folks in your group who are so passionate about research. That way you can engage everybody. Again, also having regular research meetings so that people can talk through things, keep things on their mind, a little healthy competition. We're mostly type A folks, so you can go through and kind of have different color-coded bar charts of how people are doing as far as enrolling. And then just something that I drill into our fellows, this is what works for me, but we all have our own kind of mental catches, is to always discuss for patients, kind of for me, it's a 3 pathways discussion. Oh, we have standard of care, we have clinical trials, or we could consider focusing on quality of life. And to have that discussion each time you come around to a patient discussion, even if you don't have a clinical trial available, because then that becomes something that patients feel comfortable with, and you can have a discussion about what clinical trials are outside of when you're talking to them about a specific clinical trial. So the next time they come up and you do have a clinical trial, now you have a conversation about what a clinical trial means, and it doesn't just feel like, oh, I'm at the end of the line, they must be experimenting on me. You can kind of have those conversations proactively. Then again, focusing on our patients asked, it's really important to involve your whole team. We all come back from here super energized, excited about clinical research, but not all of our staffs get to come here, and that we know that that shared sense of purpose, that shared sense of goals, not only improves our research, but also improves our group's satisfaction and increases retention. So really having that focus on why this is important, why clinical trials are important in general, and also why increasing the diversity of clinical trials for all of the staff so that they can also have a stake in it. Nothing makes your MA as happy as being able to remind you that somebody is eligible for a clinical trial and being like, oh yeah, you're right, good job. That really is very empowering for your staff. And again, then it's important that all of our staff have implicit bias training, which we've already discussed extensively today. So it's also important to make sure that our patients are there to be asked. So that means reaching out to the community, the medical community that's nearby you, especially if those are people who are practicing in other diverse areas of the city. Are they in a regional area? Are they in an enclave that has a diverse patient population that your institution doesn't necessarily serve? Make sure that you reach out, that the other GYN oncology groups in town, that you all share your research lists, that you share that with medical oncology groups, that you educate the hospital systems and referring physicians. And then it's also especially important to reach out to communities. We've already talked about community outreach, but really listening to what your community needs, what issues are important to them, which diseases are important to them, so that we can make sure that we are actively listening. And then, very importantly, are patients supported? So research has shown that addressing these social determinants of health is one of the main barriers to patients being able to participate. We all know that we're asking more of our patients when they participate in clinical trials, be it more blood draws, more CT scans. When patients have more social precarity, that is an added burden that patients sometimes feel like they can't take on, so that we need to make sure that our patients are supported. And that means patient advocates, it means navigators, it means diverse staff. It also means focusing when you're selecting trials, making sure that your trials are feasible for your patient population, and that you speak candidly with sponsors and with groups about what support matters to your patients. So for instance, I practice in a state with a very rural population with long distances to healthcare, so transportation issues, places to stay and support for housing on multi-day trials or on days that have long PK intervals is really important, and we make sure that sponsors understand that.
And then making sure that there are supportive services, that you've got, again, that clinical trial support, reaching into the stuff that your hospital already provides, making sure that you address things like time toxicity and travel requirements, and then navigators. Lastly, it's then important to make sure that we continue to improve. So we're all enthusiastic today, but a few months down the road, it's important to step back and make sure we're actually doing what we think we're doing and that we stay engaged. So it's important to keep and evaluate your data. So race, ethnicity of your patients. Importantly, reasons for missed opportunities for enrollment. Is there something that we're missing? Is there some systems way that we can fix that? Are there reasons for pre-screening and actual screen failures? And importantly, are there difficulties that patients are encountering that they're on trial that we need to address so we can remediate that? And lastly, something to take home from all of the presentations is it's important that we all keep in mind our why. Systems problems require systems fixes. We know that clinical research is the way that we move our science forward, and it's only through inclusive clinical research that we can move our care forward equitably.
We have, do you want to do questions now or? Okay, we have to do our next case and then we'll take some questions. So we have one last case that we want everybody to work on together. If you can pull that up for us.
Do you want to just get started while it's coming up?
So we have a 55-year-old Black patient with recurrent stage 3C1, grade 3 endometrial cancer. The patient has hypertension and diabetes. She was treated with 6 cycles of carboplatin and paclitaxel, which she completed approximately 9 months ago, and is presenting with a disease recurrence. She has mild residual neuropathy. Her laboratory values are significant for a creatinine clearance of 40 mLs per minute and a blood sugar of 140. Her social history is significant that she's an immigrant from Haiti and lives in a Midwestern state in a rural area. She relies on her family and friends for rides to her doctor's appointments. She has 2 supportive daughters and is a proud grandmother of 3 grandchildren. She's a non-smoker and a non-drinker. The questions we want you guys to answer are, do you envision this patient being able to enroll and participate at a clinical trial at your institution? Why or why not? What are some potential patient-level barriers to clinical trial participation that relate to her comorbidities? And then finally, what steps can be taken when deciding a clinical trial protocol to promote inclusion, diversity, equity, and access of underrepresented patients to clinical trial participation? So we'll take about 5 to 8 minutes to go over this. Okay, everyone, sorry for that short discussion, but we want to try to catch up on time. Does anybody want to share their thoughts based off of this case with the group?
So the creatinine clearance, language, transportation are the things that we talked about. We'd send the patient home with a 24-hour urine, seeing if we can bring back a better creatinine clearance to get them eligible, make sure there's a translated consent form. But I kind of wanted to go over some of the things from the last talk, if that's possible.
Sure.
So we have a systematic approach in Oklahoma. We want to be #1 in clinical trials enrollment every year.
I've heard that about you before.
Yeah. So we published an effort where all the GYN oncologists were compared to each other as to who put on the most patients. And Dr. McMeekin lost. And so Dr. McMeekin was assigned to educate all of the oncologists as to how to go about enrolling people on clinical trials. And he now is deceased, but he was able to get the medical oncologists to enroll more people on clinical trials than the GYN oncologists. And we have a competition which we publish. So every month you get a CTO report of all the people who were enrolled. on lapse studies and other NCORE studies, et cetera, and we have a competition and GYN is losing. So that's a success story. The other things that we do is that every CT scan, every pathology report, every office visit, we email the clinical trials office for eligibility, and they send us back an email prioritizing lapse studies, phase 3, phase 2, phase 1, who's eligible, what study, and prioritization. And then the research assistant meets the patient in the office on that next visit. And I always call the patient and tell them they're going to get, a lab draw and a CT scan or whatever the eligibility requirements are before that visit so we can have a thorough discussion. And then competition's good. Epic allows you to send a message, like when you're reviewing a CT scan, to the research office too. So you can just do it in the middle of the night. You don't have to worry about being daytime or whatever, so.
Those are all wonderful ideas.
So Carrie Rodabaugh, University of Nebraska, and this patient definitely hits home. Many of our patients travel 4 or 5 hours to come see us, and we have a very rich network of private practice medical oncologists across the state that we refer all of our patients to so that they can get their treatments locally and not need to travel the 5 hours to our home institution. We struggle putting those patients on clinical trial because those are private practitioners that are not part of our institution. But I'm overseeing their treatment. If NRG would allow us to be able to enroll patients remotely, then we would do all the data management. We would be able to very definitely increase our accrual.
Great. Any other thoughts or questions for our speakers? Okay. I guess you guys will single-handedly get us back on track. So we're going to move on to session 4.
So if session 4 participants can just make their way up to this podium. I'm going to introduce Brianne Bowden, who is our assistant director of the CCU and works closely with me and has a real passion in improving IDEA. And she will then moderate the patient panel. However, as we were putting together this patient panel, I wanted to just share a quick kind of text that I got. So I was communicating with one of my patient advocates who was helping me find members for this panel. And let me just pull this text up, and I'm going to read it to you. Well, Tristan can't go to Florida because it's too dangerous for a trans man there. Can't use men's restroom, can decline emergency health care, but he's connecting me with some possible other options. More to come. So this made me really sad, but it is our current state, and that's why I'm sharing this with all of you, and I'm also really honored to have Yiwan with us and represent, so thank you. With that, I'm going to turn it over to Brianne.
Good morning, everyone. Can you hear me? Okay. So I would like to just get started by having each of our panelists introduce themselves. Okay. What was, yeah. Okay. Aisha, would you like to get started?
Hi, my name is Aisha McClellan. I'm a 7-year metastatic cervical cancer survivor. I'm also a patient advocate. I work with the University of North Carolina And I sit on some boards there with the AYA group and the Patient Advocate for Research Council. And I also do work with Share Cancer Support, and I helped them launch their cervical cancer program about 2 years ago.
Again, I'm Kimberly Richardson from Chicago, and I'm the founder of the Black Cancer Collaborative, and I'm also a research patient advocate.
Good morning. My name is Mary Whitaker. I am a two-time cancer patient. This is my first time being a patient advocate, so I appreciate the opportunity to be here and share my experience and then to learn from a lot of the things that I've heard today.
Hi, my name is Yiwon Chung. I am a breast cancer survivor, and I was, my sex assigned at birth is female, and I now identify as transgender masculine. And I was diagnosed with breast cancer 4 years after having top surgery, so having chest sculpturing surgery to align with my gender. I'm also a filmmaker, so I decided to turn my experience into a documentary called Trans Dudes with Lady Cancer. And I've been using that film as a tool to educate medical practitioners.
Thank you so much. So I'd love to get the conversation started by just asking all of you, what has your experience been with clinical trials? Have you participated in a clinical trial or been approached about one? And if you would share a bit about that with us.
Mary, do you want to get started?
Okay.
Go ahead.
Okay. Yes, I am currently participating in a clinical trial for endometrial cancer. I was diagnosed in 2018 with stage 4B endometrial cancer. And after the second recurrence, my doctor recommended that I would be a very good candidate for the trial. So I agreed to the trial. Initially, my experience was not the best because I had a lot of side effects, and I was not aware of the side effects and how severe they were going to be. But after I did some research on my own at one of the .gov websites, and I read and found out that the side effects that I was having actually were expected as part of the medication that I was taking. But as I've been listening today, one of the things that I realized that did happen, and that when I first enrolled in it, I was not given like a full packet of information with all the side effects and the purpose of the study. So what I was going through was kind of new and difficult for me. But the reason why I continued in the study is because, having stage 4B cancer, was like life or death matter. So I figured it would be in my best interest to go ahead on and participate in a trial, not just for myself, but to find maybe information or medication that could benefit women, in the future. And fast forward now to 2024, I'm still here, and I'm progressing quite well in the trial. I moved in 2021 because my cancer came back in 2021. So I was in Louisiana when I first started the trial, and then I moved here to Orlando, and I became a part of the same clinical trial that was being held at the Advent Medical Cancer Institute, Research Institute. And my experience from the first facility to this facility where I am currently was night and day. Even though I had already been enrolled, I received a packet with all the information. My doctor, my care providers went over all the information with me. And the side effects are not as severe. The few that I am having, we talk about it. She goes over the information with me, and we talk about how I want to be treated medically for the side effects. For instance, I have a case of neuropathy that I've developed. And so rather than, she asked me if I wanted to take there were some pills that you can take for it. I don't know the name of it, obviously. Or if I wanted to use some, she recommended some other essential oils that I could use, and it worked very well. And I preferred to do that than to take some more medication, because I'm already taking medication, for the cancer, the pills, and then the infusions. So I didn't want to take another pill, but as it stands right now, I'm doing real well. The doctor, the care team that I have, they're just the absolute best. So my experience has been quite different now. And I asked if I could give a shout out to my doctor. My doctor is Dr. Natalie McKenzie, and she's just the absolute best. And because of what the treatment and the care that I've been received since I've been here, I have become an advocate, and I share my experience. I share the information with other women, family members, because like we've heard, sometime in the African American community, we don't trust trials. We don't trust doctors. I didn't trust doctors. Okay, I still have some apprehension for some doctors, but because of the care team that I've had here, my trust level has increased. So the trust level can be increased, and we can overcome past biases and overcome past feelings.
Mary, how can we do that better? How can we help you overcome those feelings?
Just by being more personable, showing care, concern, empathy, being there emotionally, taking the time to answer questions in details. Because even though I went to the .gov website and read about the clinical trial and the side effects, as a layperson, I didn't understand 75% of what I was reading. But I understood enough to go in and talk to my doctor and ask some questions. And one of the things I really liked about it, she would just sit there and talk to me, whereas the initial doctor, he was in and out in 2 minutes. Okay, sometimes not even reviewing the CT scan results or the blood work results. But this doctor, she sits down and she explains those things to me. She goes over, and then her care team, the research team, the nurses, they actually come in and talk to me also before she even gets the chance to come there. So I feel seen, I feel heard, and I trust them. So when they tell me something, I trust what they're saying, because they've shown me that they truly do care. And my doctor also has another program that she has implemented with some research funds. It's called the HEAL program. And what it looks at are the 6 pillars of well-being. So while I was initially going through the treatments, there was an 8-week program where she looked at our emotional health, our mental health, our nutrition. She brought in a life coach, because there's a lot more going on with a patient who's going through cancer treatment than just the actual medication, taking the medication itself. So that's been a real big help for me to have the full circle of care, mental and emotional, to support me.
Thank you so much for sharing that, Mary. It sounds like, that communication and really receiving the information you needed and just feeling cared about holistically as a whole person really went a long way for helping you to feel that you can trust your providers. So I'm so glad to hear that. Aisha, would you like to share, have you had an experience with clinical trials?
Yes, so, sorry. So my experience is similar to yours in the sense, so I was initially diagnosed with stage 2B cervical cancer. And while I was on treatment, my cancer metastasized to my lungs and liver. They didn't know that because I was only getting scanned from the waist down. So it wasn't until my follow-up scan that they saw that it had spread. And my doctor essentially was like, you know, you're probably looking at around 3 months minimum to live if you don't do treatment. Best case would be 6 to 24 months, but you know, you have to think about the quality of life you might have under this treatment. And that was kind of basically it. He just kind of sent me home, and that was that. And so I'm a single parent, and you know, I don't have a lot of support, and so I just immediately went into like fight mode. I was just like, there's gotta be, like, I feel good, you know, I look good, I can't really be doing that bad. And so I immediately went into, I did a lot of research on my diagnosis, and I wanted to educate myself because it just didn't seem right? And so I got a second opinion from a doctor. I got a second opinion, and you know, while she agreed with what she saw on the scan, that's where empathy comes into play, because she said, you know, I agree with what I see. It doesn't look good, but you're 32, you're a mom, like, I think you could handle treatment better than what he's saying, and let's try to do everything we can do. And I had done my research on clinical trials, and I brought that to her, and she was basically like, you know, this is the baseline. This treatment is always going to be here, so you can go explore the clinical trial if you want to, and if you don't want to proceed with that, you know, this will be here when you get back. And that just made all the difference. You know, it was just like she didn't blow smoke, or she didn't give me false hope. She was just like, you know, we're going to do what we can do. And you know, so I didn't end up exploring the clinical trial just because it was like 2.5 hours away from me, so logistically I couldn't really do it. But I'm glad that I at least, you know, looked into that for myself. And yeah, so that was 7 years ago. So.
Thank you so much for sharing that. You bring me to my next question, which I wanted to ask you all about barriers. In your experience, have you encountered any barriers in regards to participating in a clinical trial, or are there any that you have observed or could identify as a potential barrier?
Well, yeah, so the clinical trial that I was going to participate in, it was in Charlotte. I live in Chapel Hill, and so it was just hard logistically to get there. And I think that they did incentivize it a little bit. I mean, I think they offered maybe hotel reimbursement or something along those lines, but it just wasn't feasible for me, just being a single parent with no resources. But also, I mean, the biggest barrier is the fact that the conversation wasn't started. And you know, that's a big problem. You know, when I was first diagnosed, it took me 3 times going to the doctor for abnormal bleeding for somebody to see me. I didn't have health insurance. I was going to a local clinic, and I was just dismissed so many times. And then I just find it very interesting that when my cancer spread, I ended up getting a different job with better benefits, and I just saw a lot more doors open once my health insurance status changed. And somebody approached me about a clinical trial, but nobody started these conversations with me to begin with.
Yvonne, would you like to share?
Yeah, I would like to. So I've never participated in a clinical trial, nor have I ever been asked to be in a clinical trial. And so in preparation for this, I went to clinicaltrials.gov, and I typed in breast cancer, ovarian cancer, and right away I see barriers in the inclusion criteria. So often, you know, in the inclusion criteria, it might talk about female of a certain age to participate, and then the language goes on to talk about women who do this or do that, or not do this or do that. So that in itself, terms and language in itself was already something that I would have, you know, basically said, this is not for me. So, you know, and in reading more of that particular trial, and many of them, right, the language is written that way, my sense is that it is actually trying to do some research around, or a trial around someone who is sex assigned at birth female, right? And not necessarily gender being cisgender, but the language is written in such a way that it just didn't include me as someone who is not cisgender. So I don't know if I need to explain terminology. Cisgender is the opposite of transgender. Hopefully that makes sense. So when someone's sex assigned at birth, so, you know, shortcut being biologically female, and now identify as a woman, that is cisgender. So for me, my sex assigned at birth is female, but I identify as transmasculine. That makes me transgender.
Yiwan, thank you for your honesty and vulnerability. And it brings up this whole issue of intersectionality that exists as a barrier in some of our clinical trials for many of our patients. And I would challenge each of us when we go back to look at how we collect SOGI data in our electronic health records, because it's very incomplete, and some of it certainly defaults back to gender assigned at birth, and it's very challenging for us to get the full spectrum of how people self-identify. So thank you for that.
I'd like to add a little to this as well. I personally have not been involved in clinical trials. I've done more behavioral research studies, but one of the things I think that's really important about my work as an advocate is reducing that gap. And so when I think back to when we started this work with community health workers, we were looking for Black and Latina and Latine trans community health workers. We wanted to get to that population, those subpopulations. We want to talk to those who have mental challenges, and what is that going to take for them to be able to participate in clinical trials when perhaps someone else has their power of attorney? How do we help and protect women and transgendered men who may have mental challenges in relationship to gynecological cancer? How do we translate that information, right? And getting the opportunity personally to sit in on listening sessions and do focus groups with transgendered men and non-binary people on this whole concept of the patient encounter. Why don't I want to go to the doctor and be seen and get services and find out more about risk symptoms and risk factors if I don't feel comfortable going into that environment? And so then how do we take that information about the encounter and translate that back to curriculum for the medical student, right? And so these are the ways when you're listening to these lived experiences, it's not just oh, that was interesting and gee, that's inspiring, but how do we translate what we're hearing into either policy or curriculum changes that changes behavior in that patient encounter?
Yeah, absolutely. I think, Kimberly, you and Yuan both kind of touched on the importance of feeling comfortable and that sense of inclusion, and then how we can translate that and apply those feelings to all patients. If there was one thing that you could have our audience take away from today's conversation, what would it be? Yuan, can we start with you?
Sure. I would say, do not conflate sex and gender. They're two separate things. Do not conflate sexual orientation and sexual behavior as well. All right, I'm going to let you sit with that a little bit. So, you know, again, in the education work that I do through my film, I talk about how if you have the part, you have to get it checked. And sometimes the part doesn't necessarily align with what we understand as gender. So I think this requires a shift in mindset, but also systems. So what I mean by mindset, right, is how do you talk to someone and not assume what body part they have by looking at them? And with the systems and structure, from how you collect information, how you collect data, and then are you actually doing something about it? And I think part of it will be also to start at the medical school level, to decouple, right? And sometimes the shortcut is not helpful, not just for transgender people, but also for cisgender people. So my story is that I had chemotherapy, radiation, a double mastectomy, and then I had hysterectomy as part of all of my cancer treatment. 4 years later, well, doesn't matter how long it was, I still get email from my health insurance. Once in a while, they will send me an email and say, hey, it's time to get your pap smear. And so they know that I had a hysterectomy and that I don't need a pap smear. And so if I'm getting that email, I think that some cisgender women are getting that email as well that may have had a hysterectomy. So this is what I mean by what we bring up in this education around transgender health and being more inclusive of transgender people will actually benefit everybody, including cisgender people. And then another context that I want to provide is that in the US, there's an estimated 1.6 million people who are transgender. It means that there will be 400,000 of us, trans people, will have a cancer diagnosis in our lifetime. So when we mean all, we should mean all, right?
One of the things that I'd like to share, well, actually I have two things to share when it comes to takeaways. One of the takeaways is I've heard a lot of discussion about low income or people who really lack the resources or the financial ability and insurance, but sometimes those of us who are not low income and we do have the financial resources, participating in a research study can still be very taxing on us, on our families, on the resources that we do have. And I know sometimes I was really too sick to drive myself to the doctor to get my medication. So I actually, out of my own pocket, paid somebody to do, to care for me, to bring me, and to wait with me while I went through the treatments. So the fact that there may be some financial assistance, not just because we're poor or we don't have the financial resources, but there is a strain on the family finances altogether, above and beyond what insurance will pay for. And then the second thing that I want as a takeaway is to just be more encouraging to the doctors. And I want to thank the doctors because you obviously do care about taking care of us. You obviously do care because you took the time to come here and participate in this symposium. So that shows that you do care. And that's encouraging to me as a patient. But also for those doctors who may not realize it, that taking the time to talk to me as a patient and share the information with me is very important. Connecting with me, showing compassion to me. That helped me not just with staying in the clinical trial, but also, I believe, progressing well in the clinical trial because, you know, it makes me, I want to do all the things that my doctor recommends me to do because she's important to me and I know I'm important to her. So she recommends that I don't eat processed foods because it's not in the best interest of my healing process, then I'm going to do that, okay? Because I trust everything she says, and I really want to do well in the clinical trial because of her. So I just want to say thank you, doctors, for caring and taking the time to participate in this the symposium. I've really learned a lot as a patient, so I can go forth and I believe be a better advocate and share that doctors do care, even though sometimes you're really, really very busy. You don't have time to show how much you do care, but it's important to us, so thank you.
I will add on to what Mary said. We intuitively know that you got into these fields because you had these altruistic characteristics. And somehow throughout your training and your practice, it's sort of gotten beaten out of you. And it sometimes shows up in these patient encounters. And so I really would love to say that we as patients want all of this from you. But I also want you to walk away with thinking about your team. And if you don't have the necessary skill set to be empathetic or have time to listen or don't really see yourself as that caring person you used to be, make sure your PAs are, right? Make sure your nurses are. Make sure your oncology nurses are, because that's going to keep the trust level up. Someone just recently mentioned to me that in those conversations, in those patient encounters, the little notes that could be taken prior to getting in front of the doctor. Because when you come in, we just go, we're okay. But what we've told the nurse, what we've told the front desk, the people who talk to us all the time, we've told them a completely different yet personal story. You guys don't have time for all of that, but you do need to know that those things exist, and you need those characteristics in your team members. In addition, I'd like to add as my second takeaway, add patients and survivors and caregivers as advocates to your team, both in your medical practice as well as in your research. There are things from our lived experiences that can be added to your research protocols. It could be added to how the informed consent is conveyed to the patient. We can often tell you a lot more about adverse effects of the drugs that can change the way the pharmaceutical companies are dealing with the drug in terms of dosage and toxicity. A lot of things that we can add to the conversation without taking anything away from you as providers and scientists. So thank you.
Yeah, and just to mimic that's one of my biggest takeaways. I think that as I get more involved in patient advocacy, I don't know that providers see the value in what patient advocates have to offer. I think that, anytime I've been approached to do anything for advocacy, it's always volunteer-based or something like that, and which is great. I'm glad to volunteer. I'm glad to do all these things, but we're just as important as a nurse navigator or anything, and so I just think that we just need to work on recruiting more patient advocates and also just see the value in the things that we have to offer. That's probably.
Just before I turn this back over to Brianne to close us out, I just want to stand up a couple of themes that came up for me. In particular, I hope everyone heard what Ms. Whitaker said. Sometimes we typecast and stigmatize people who are from minoritized and racialized communities that are also of lower socioeconomic status and may have more social determinants of health issues. That's not always the case, because when you control for social determinants of health, there still are fewer people from those communities that get enrolled in clinical trials. So Ms. Whitaker, thank you for saying that. And then the other thing, two other things. One, the importance of concordant teams, and whether those teams are concordant by race, sexual orientation, gender identity, rural geographic status, it's important that our teams be reflective of that. And then finally, Ms. Richardson, you mentioned Shalone Irving, who is a Black CDC physician who died at childbirth. Again, if you go to her eulogy says, she could not outdress this, she could not out-access this, she could not educate this. It was because of something else that was going on. It was due to her race and ethnicity. So these factors are clearly important in the work that we do. Brianna, I'm going to turn it back to you to close us out.
Thank you so much. I just want to sincerely thank our patient panel, our advocates, for being with us here today and offering such a insightful perspective. Your thoughts, your opinions, your experiences are so valued, and really, I think I speak on behalf of everyone here today when I say thank you very much for being here with us.
Thank you. You guys were amazing. I always learn something from all of you, and I so value your participation. So really thank you all for being here. I hope everyone learned something, and will take away some of these tidbits and start incorporating them into your daily practices, and that we will send out, additional resources, but please continue this conversation, and let's continue to make progress in this area. I want to thank Michelle Small, who has worked tirelessly to make all of this happen. Have a great day.